I spend about half my time taking care of patients and the other half of my time running clinical trials, often very big international clinical trials. So first, it is fabulous to be back face to face. spend about half my time taking care of patients and the other half of my time running clinical trials, often very big international clinical trials. So first, it is fabulous to be back face-to-face here at ESC, COVID pandemic under control, because so much of this is about relationships. And so it's great to collaborate and network with my colleagues from around the world. What I think is most promising with regard to clinical trials is the opportunities that technology brings to make trials simpler and faster and more patient-centric and take more of the trial to the patient rather than the patient having to come to the hospital or the trial site. And with more clinical trials, better, faster clinical trials, we get better quality evidence and can take better care of patients. So that's what I think is most exciting. One thing that we all have in common is we're getting older. It's really critically important that the next generation of researchers learn from the current generation of researchers, and the best way to learn is by doing. And so I would encourage young investigators who are interested in clinical research to network. Go meet your peers who are interested in clinical research, go meet the older clinical trialists and figure out how to get involved. And there's lots and lots of opportunity. And I think the cardiology clinical trials environment is very supportive of bringing up junior investigators into important roles in clinical trials. So it's an important thing that I'm passionate about and part of my career. And I think it's really about networking and making relationships. I'm John Alexander. I'm a cardiologist and professor of medicine from Duke University in North Carolina in the United States. Factor XI inhibitors are a new class of drugs that inhibit one factor, factor XI, in the coagulation pathway. And they're really new, and there are about 4 or 5 of them that are in development. Asundexian, which is being developed by Bayer, is one of them, and that's what we studied in Pacific AMI. And the hope is that they will have some advantages over existing antithrombotic drugs, like aspirin, like the P2Y12 inhibitors, clopidogrel, ticagrelor, and prasugrel, and like other anticoagulants, like vitamin K antagonists or warfarin and rivaroxaban, that have limitations, that have benefits, but also have limitations in patients after an acute myocardial infarction. So we like to lump all anticoagulants together, but they're really different. So factor XI is in the contact activation pathway, and asundexian inhibits it. Rivaroxaban, andapixaban, and edoxaban inhibit factor X. Factor X is necessary for the initial generation of thrombin, and we think that thrombin is key for hemostasis, to stop blood, to cause a blood clot, to stop bleeding. But thrombin has a feedback loop and generates this huge explosion in thrombin generation and activity, and that is through the pathway, the contact activation pathway that includes factor XI. And so inhibiting factor XI, we think, will inhibit this burst of thrombin activity and hopefully prevent recurrent heart attacks and recurrent strokes, but still allow a little bit of thrombin to be generated to stop bleeding. So Pacific AMI was a phase 2 clinical trial. We studied patients with a recent acute myocardial infarction. People could be enrolled within 5 days after their acute MI. They had already undergone PCI, or the initial stabilization after their acute MI. And all patients were treated with aspirin and one of the 3 available P2Y12 inhibitors, clopidogrel, prasugrel, or ticagrelor. And then patients were randomized to one of 3 doses of asundexian, 10, 20, or 50 milligrams a day, or placebo. And then they were treated for up to a year, and we followed patients for that year plus an additional 2 weeks. Our main outcomes were factor XI levels, bleeding, and recurrent ischemic events. We saw a nice dose response in the level of inhibition of factor XI. So the 10 milligram dose inhibited about 70% of factor XI, the 20 milligram dose about 80%, and the 50 milligram dose more than 90% of baseline factor XI activity. So that's good. We got the drug work to inhibit factor XI. there was really no increase in bleeding with factor 11 inhibition, including at 50 milligrams. So that's consistent with a hypothesis and is really why these drugs are being developed. So no increase in bleeding. Unfortunately, we didn't see a reduction in ischemic events either, but you have to be careful. This is a phase 2 trial. There were only about 20 to 25 events per arm, and the confidence intervals are still really wide. So this sets the stage for the next trial, the phase 3 trial. Bayer, the sponsor, has a large phase 3 trial program planned that'll include trials in atrial fibrillation and stroke. We're still in discussions with the sponsor, with Bayer, about a phase 3 trial in acute MI. There's not one planned right now, but we're still trying to figure out the perfect design. This is going to be, the next 10 years, you're going to see a ton of results around factor 11 inhibitors, just like we have for the last 10 years around factor 10 inhibitors. And it's quite likely that they will revolutionize the way we take care of patients. So stay tuned.
Well, I think it's a great time to be a scientist, especially in the field of cardiovascular disease. Myself in particular, I'm a stroke neurologist who's interested in stroke prevention, as well as the interface between reducing ischemic vascular events and people who are prone to bleeding. And particularly now with the emergence of factor 11 inhibitors that may be able to reduce thrombosis without increasing the risk of bleeding, as well as some anti-inflammatory medications such as colchicine that could also do the same. I think is really exciting new paradigm of medications that will be able to further reduce ischemic events without translating to a higher risk of bleeding. And this will be particularly important in older patients who have intrinsic small vessel disease of the brain that lead to hemorrhage, or those who have already had bleeding in the brain. And with advances in technology and pharmacotherapy and mechanical treatments, I think right now we're really at a kind of exponential increase in potential therapeutics that could help our patients. Definitely being a clinical investigator, a clinical scientist is challenging in terms of trying to balance work-life, priorities and demands. However, it is very, very worth it. And some advice is find a strong altruistic mentor. I would never be in the position that I am now presenting these results if it wasn't for very strong and kind and altruistic mentorship that I've had in my institution. So there's people like Robert Hart, Mike Sharma, Stuart Connolly, as well as other very impactful people throughout my training. And if you happen to fail, try and try and try again. For instance, for grant writing, getting rejected is basically the rule initially, and you have to keep trying until you get your first grant. And then try to adapt to the strengths of your environment, right? You're going to be shifting from one institution to another, from when you go from training to clinical practice, and sometimes the strengths there may not be what you're used to, but if you adapt to them, I think that's your greatest chance of success. Hi, my name is Ashwin Shwamanesh. I'm an associate professor of medicine in the Division of Neurology at McMaster University and a stroke neurologist and scientist at the Population Health Research Institute in Hamilton, Canada. There's a large unmet need that's being addressed with the Pacific Stroke Trial. We are targeting patients with non-cardioembolic ischemic stroke. This subgroup of ischemic stroke patients accounts for 75% of patients who suffer an ischemic stroke. And in 2019, there was about 12 million individuals with stroke worldwide, or incident stroke worldwide. At present, despite guideline-recommended treatment, there's a substantial risk of stroke recurrence in patients with non-cardioembolic ischemic stroke that is above 6% per year. So our aim and the importance of this study is to be able to address this unmet large residual risk of stroke recurrence. And we're also using a novel medication that may be able to further reduce this ischemic stroke risk without increasing bleeding, which is of course kind of the offsetting potential harm when you use blood thinning medications in these patients. So the Pacific Stroke trial was a prospective, randomized, double-blind, placebo-controlled, phase 2 dose-ranging study. Patients with non-cardioembolic ischemic stroke who presented within 48 hours of symptom onset were randomized 1:1 to 1:1 to 3 doses of asundexian, which is a small molecule direct factor 11A inhibitor. And those doses were 10 milligrams, 20 milligrams, and 50 milligrams daily. And they were compared against placebo. Our primary efficacy outcome was the composite of recurrent symptomatic ischemic stroke and covert brain infarction on MRI. As a result, all patients also had to have had an MRI either prior to randomization or up to 72 hours post-randomization and at end study or 6 months. The eligibility criteria additionally mandated that patients be at least planned to be treated with antiplatelet therapy throughout the duration of trial participation. So this was using asundexian on top of background clinical care antiplatelet therapy. It's a very important question because that's what's really exciting about factor 11A inhibitors, and in particular asundexian, is that through direct inhibition of factor 11, there's a potential, and very exciting potential, to be able to reduce pathologic thrombus formation without increasing the risk of bleeding. And the reason for that is that factor 11 plays a very direct role in amplification of thrombus or thrombus propagation that we think leads to pathologic thrombus formation. On the other hand, it has a much lesser or subsidiary role in hemostasis. So there is a very strong rationale why these medications may reduce thrombosis without resulting in an increase in bleeding. And there's a lot of epidemiologic data in patients who have factor 11 deficiency and so forth that support this. In addition, for a population of stroke, it is important because we know that patients with ischemic stroke have higher levels of circulating factor 11, and also those who have inherent factor 11 deficiency have lower risk of stroke compared to the general population. So it makes it a very attractive candidate for optimizing stroke prevention. So our primary analysis did not demonstrate a dose-dependent effect on the composite outcome of recurrent symptomatic ischemic strokes and covert brain infarcts on MRI. However, this was driven by a lack of effect on covert brain infarcts, which accounted for about 75% of our composite primary outcome. When we look at the more clinically relevant outcome of symptomatic ischemic stroke, there was a suggestion of a 20% relative risk reduction with asundexian 50 milligrams relative to placebo, and this is not reached statistical significance, but there was a strong numerical trend there. And then when we looked at the post hoc exploratory outcome of the composite of ischemic stroke and TIA, we did notice a dose-dependent effect in reducing this composite outcome with asundexian, leading to roughly a 35% risk reduction in this outcome with asundexian 50 milligrams daily versus placebo. And we were also very interested in looking at subgroups of patients that had indication of atherosclerotic disease. And this was based on another trial called the COMPASS trial, where patients who were receiving rivaroxaban with or without aspirin, the combination of low-dose rivaroxaban and aspirin, and who had systemic atherosclerotic disease, these patients had improved ischemic stroke reduction with combination therapy or dual pathway inhibition when combining a small dose of an anticoagulant with an antiplatelet agent. So for this reason, we were very eager to see our effects in patients that had indication of systemic atherosclerotic disease. And we looked at this in 2 ways. One, we looked at patients who came into the study and their qualifying stroke met criteria to suggest it was due to large artery atherosclerotic disease. And in these patients, there was a larger effect size of a 45% relative risk reduction in the composite outcome of ischemic stroke and TIA with asundexian 50 milligrams daily versus placebo. And in those that had any indication of atherosclerotic disease, so they had atherosclerotic disease on vascular imaging of their aortic arch, carotid disease, or intracranial vessels, in those patients there was actually a very robust 60% relative risk reduction and the composite outcome of ischemic stroke and TIA with the 50 milligram dose versus placebo. And this was all combined with no suggested increase in bleeding. So we did not find a significant increase in our primary safety outcome, which was the composite of major bleeding or clinically relevant non-major bleeding as defined by the International Society of Thrombosis or Hemostasis. I think, well, the take-home message is, one, of course, this was a phase 2 study, and the results are too preliminary to be implemented in clinical practice at this time. However, very, very exciting results demonstrating potential strong efficacy with asundexian relative to placebo, particularly the 50 milligrams daily dose, for addressing this unmet need of high rate of recurrent stroke in this population, particularly in those with atherosclerotic disease, and importantly, without increasing bleeding. So I think these are very promising and exciting results for a subsequent phase 3 trial to confirm these findings before they're applied to clinical practice. So we're really, of course, excited to see if we can confirm these findings in a phase 3 trial, and we're working towards the development of such a trial.
You know, I think I've been excited about cardiovascular science since I was in medical school. It is a rapidly developing field, and the developments have just continued to increase. One of the nicest things I have to say about 2022 is meeting people again in person. Research is a collaborative effort. You bounce ideas off each other, and I can't tell you how nice it's been now to sit with colleagues, some of whom you haven't seen in person in over 2 years, and talk over ideas. There are really exciting developments happening right now in the field of prevention, Lp(a), and what we've been working on with factor XI inhibition. I think we're in the dawn of entirely new classes of agents to help prevent disease. I think that the best advice I can give was something I received when I was young, and that is research should be fun. So do things you enjoy, do them with people that you like working with, and you'll end up being more successful than you realize. You're going to spend a lot of time and effort doing research, and you don't want it to be drudgery, you don't want it to be painful. Focus will come as soon as you find things that you enjoy. I'm Mike Sharma. I'm a stroke neurologist at McMaster University and the Population Health Research Institute in Hamilton, Canada. So patients who've had a recent ischemic stroke or high-risk TIA have an absolute risk of a stroke within the first 90 days between 6 and 10%, so really quite high. We've made some advances with antiplatelet agents using aspirin in combination with clopidogrel, and most lately aspirin with ticagrelor. These things, however, have come at a cost of increased bleeding. So the standard of care at the moment for minor ischemic stroke, high-risk TIA is dual antiplatelet therapy. The reason we chose to add this factor XIa inhibitor on top of dual antiplatelet therapy is that we wanted the comparator to be the best standard of care available to us. It also gave us the opportunity to test the safety of this agent in combination with antiplatelet agents. And certainly at phase 2, when we don't have evidence of efficacy, we did not want to leave patients in the trial without the standard of care. So as a result, patients in axiomatic SSP received one of 5 doses of milvexian on top of aspirin and clopidogrel for the first 21 days, and then aspirin from day 22 to day 90. So we looked at patients who had high-risk TIA, defined as having an ABCD2 score of 6 or 7, or motor symptoms, or mild to moderate stroke, NIH stroke scale of 7 or less, and we randomized them within 48 hours of symptom onset, so very rapidly after the occurrence of the index event. The strokes were non-lacunar and non-cardioembolic, so we avoided patients who had an indication for anticoagulation and also small vessel disease, which appears from previous studies to respond less well to antithrombotic therapy. All patients, whether they came in with TIA or stroke, had to have visible atherosclerosis in a feeding vessel. So it could be in the aortic arch, in the carotids, in the vertebral arteries, depending on the area of the brain that was affected. They were randomized to one of 5 doses of milvexian or matching placebo, and the doses had a 16-fold range from 25 milligrams once a day to 200 milligrams twice a day. Everyone was on dual antiplatelet therapy, aspirin and clopidogrel for the first 21 days, and then on aspirin 100 milligrams a day by itself from day 22 to day 90. Our composite efficacy endpoint was a combination of symptomatic ischemic stroke and covert infarcts. So these are infarcts we detect on MRI, looking at the 90-day MRI compared to a baseline MRI, so we know they've occurred during the period of the study. In the primary outcome, which combined covert infarcts with symptomatic ischemic stroke, we saw numeric reductions in this outcome for the 50 milligram twice a day and 100 milligram twice a day doses, but overall we did not see a dose response curve. However, when we looked at each component separately, what you note is that the covert infarcts don't respond at all. However, symptomatic ischemic stroke did respond. Every dose of milvexian, apart from the highest dose, had a lower rate of stroke than placebo, and there was a 30% reduction compared to placebo for doses between 25 milligrams twice a day and 100 milligrams twice a day. This all occurred with really outstanding safety. There were no fatal bleeds. There was no increase in intracranial hemorrhage or hemorrhagic transformation of the ischemic stroke. Most of the bleeds that we saw were GI bleeds, and the rate in our trial ranged from 0.6% to 1.5%. Again, there wasn't a dose response for bleeding. However, numerically increased in the 50 milligram BID dose and higher doses. So, the real prime function of a dose-finding trial such as axiomatic SSP is to find a dose that we can take forward. Here we have 3 doses with efficacy that was actually higher than we predicted at the outset, and outstanding safety when combined with antiplatelet trials. So the next step is an adequately powered phase 3 trial, and I think likely to study a similar population to the one we studied in phase 2. So that should start as quickly as possible. So, I think that if we get to the stage where things work as we expect, there'll be a huge impact on patients. Stroke is a devastating condition, and we have about 12.2 million strokes each year in the world, and it results in significant disability. So looking at these patients who are at highest risk of death or disability due to stroke and reducing the chance of that occurring, I think is of great benefit. What's limited us in the past is the bleeding hazard, and what we see early on is benefit without a significant increase in bleeding. I do want to say that that we have to be careful in our claims. It's not the case that we expect no bleeding. We will see some bleeding with all antithrombotics, but we hope that the trade-off is as we predict, and the serious bleeding just doesn't occur. So this has a potential to really revolutionize stroke prevention. For clinicians, I think that having a very effective tool in the toolbox is important. If things work as they did at phase 2, I think we're going to have to be more conscious as clinicians of the underlying stroke subtype, and particularly look early for atherosclerosis underlying the stroke.
I'm Harriet Vansball, Associate Professor of Medicine and Cardiologist from McMaster University in Canada, and I'm absolutely delighted to have with me Professor Karthik from the All India Institute of Medical Sciences, and we are here at ESC 2022 to discuss his late-breaking clinical trial presentation of the Invictus trial. Welcome, Karthik.
Thank you, Harriet. Pleasure meeting you here.
Likewise. I'm going to start by asking you to give us some background so that our viewers can put Invictus in context of current knowledge about atrial fibrillation and rheumatic heart disease and anticoagulation regimens that have been evidence-based to date, and tell us what knowledge gap this trial fills.
So, as you know, rheumatic heart disease is a disease of poverty. It affects people mainly in low and lower middle income countries. And the problem with rheumatic heart disease as such is that these are young people who develop AF much earlier than non-valvular AF. They are at higher risk of stroke much earlier in life. And when they develop strokes, they develop large strokes, and it's pretty debilitating, and the subsequent burden and mortality is known to be high. So the second part of the problem is that the classic trials of anticoagulation and atrial fibrillation explicitly excluded patients with rheumatic heart disease, particularly the ones with mild stenosis, because they felt at that point in time that these were patients who were at prohibitively high risk of stroke, and it was probably unethical to randomize these people. So as a result, you had the first trials of VKAs versus placebo, from which RHD patients were systematically excluded. And then subsequently, when the DOAC trials were done against VKAs, because these were non-inferiority trials, they again had to exclude patients with rheumatic heart disease. So as a consequence, you have 0 RCTs for patients with rheumatic AF in terms of stroke prevention. So this is a very big knowledge gap. And the third point is that as a result of all this, treatment of patients with rheumatic AF is empirical, and people give VKAs in developing countries. But the biggest challenge with using VKAs, as you all know, is the INR monitoring. And INR monitoring is very challenging in developing countries. And data suggests that about just half the patients who are eligible for anticoagulation go on anticoagulation with VKAs. And even among those who are on anticoagulation, only about a third maintain an INR in the therapeutic range. So it's pretty dismal. And so we felt that, if we used an anticoagulant which does not need monitoring, and if we find that to be effective, this would be of great benefit to these patients.
So tell us about your trial design and how you tackled the question, your research question.
So our research question was pretty simple. The question that we asked was, is rivaroxaban non-inferior to vitamin K antagonist dose adjusted for, as originally planned, reduction of stroke or systemic embolism? We did this trial in about 24 countries, 138 centers around the world, all in the RHD endemic countries. So we have most of the patients coming from Africa, the Middle East, South Asia, some other parts of Asia as well, including China, and then also Latin America. So we have about 24 countries participating, and we recruited about 4,500 patients. The dose that we used was pretty straightforward, 20 milligram per day of rivaroxaban among patients with normal renal function. Anybody who had a calculated creatinine clearance less than 50, we used the 15 mg dose. And we used, for the purposes of VK, any locally approved VK in all these in these participating countries. So most of it was warfarin, and about 15% was acimaclomorol. So very standard, straightforward treatment. And we encouraged INR monitoring in patients who were on BK, and we tried to bring it up. This was a non-inferiority trial, so we needed to make sure that the control arm was treated well. Otherwise, it would have affected the integrity of our trial. So we did that with a simple algorithm which suggested a 10% dose increase or decrease every month. So that's how we went about it.
And what were your inclusion and exclusion criteria?
So we included patients who had echocardiographically proven rheumatic heart disease with documented atrial fibrillation or flutter. In addition, we required that, because these patients are very young, we required that they needed to have at least one additional risk factor for stroke. So the two most important ones were the presence of moderate mitral stenosis, which we defined as a mitral valve area less than or equal to 2 centimeters square, or a CHA2DS2-VASc score of 2 or more. So these were the two primary inclusion criteria by which patients qualified to enter the trial. Of course, if they had left atrial thrombi or if they had spontaneous echocontrast, they could also enter the trial because they were considered at higher risk of stroke. So these were the primary inclusion criteria. And so our primary outcome, like I said, was initially stroke or systemic embolism, but then during the course of the study, we noted, blinded to the treatment allocation, that our event rates were very, very low. The stroke event rates were very low. And the deaths were far higher, about 6 to 7-fold higher. So these were sick patients. The patients who were at risk of stroke were also dying. So we were unlikely ever to reach our primary endpoint as we had originally planned. So blinded to the treatment allocation, treatment arms, the steering committee decided at somewhere in 2020 to expand the inclusion, the outcomes to a larger composite, which included MI and deaths of vascular or unknown causes. So the final composite that we've analyzed and presented is a composite of stroke, systemic embolism, myocardial infarction, or deaths due to vascular or unknown causes. This is quite similar to a previous trial, an old trial, which was led from PHRI McMaster, which was the Active W trial. They used a similar composite at that point in time. That was also a AF trial. So that's our modified composite outcome.
Right, and important to mention, as you did, that you were blinded to treatment allocation when you had this change in protocol. Tell us about the baseline characteristics.
Yeah, so in summary, there are 4 or 5 important things that we need to remember when we look at the patients who were recruited into Invictus. First of all, they were young patients, average age of about 51. This is about a decade and a half or 2 decades younger than the regular non-valvular AF patients who've been included in these DOAC trials, for example. The second thing is there was a female preponderance. About 70% of patients were female, and this is very much in sync with what the prevalence of RHD is among females. So that is one thing which is very different from non-valvular AF. The third thing is 85% of patients had moderate mitral stenosis. And out of these patients, about 2/3 had severe mitral stenosis as defined by mitral valve area less than 1.5 centimeters square. So these were patients predominantly with mitral stenosis. The fourth important thing was that the conventional risk factors for stroke, atherosclerotic risk factors like hypertension, diabetes, or coronary artery disease, was infrequent in this population. So as a consequence, you have about 45% of patients who have a CHA2DS2-VASc score of either 0 or 1. So in terms of stroke risk, this is not conventional, by conventional metrics, this is not a high stroke risk population.
Right.
So, yeah.
Okay. And what were your event rates in the control group?
So the stroke event rates, overall the stroke event rates were about 1%. But the overall event rates for the primary composite is about 8.5%.
Okay. And what was the follow-up duration?
So we had about 4,531 patients followed up for about an average of 3.1 years.
Okay.
We had excellent completeness of follow-up. We had about 97% full follow-up. Remember that this whole trial was done in very poor countries where it was pretty challenging, and we also had to go through the COVID pandemic. So despite that, we achieved an excellent rate of follow-up in these patients. And so at the end of 3.1 average years of follow-up, we are now we have a
Ready to give the
Kind of
results
results,
away. But before you do that, tell me about the INR achieved in the group that was on VKA therapy.
So there are two aspects to it, right? So in the study drug, rivaroxaban, the compliance rate for rivaroxaban, rates of complete discontinuation, permanent discontinuation at the end of trial was about 23%, which is in the ballpark for all the other DOAC trials. So there's nothing alarming about that. So this is what is typical. On the other hand, patients on VKA had an excellent compliance. So typically in the DOAC trials, the rate of permanent discontinuation was similar in both arms. So about 20% of patients at 2 years typically go off the trial. But in Invictus, in the VKA arm, just 6% of patients were off drug at the end of study, and at the end of 3.1 years of follow-up. So that is a pretty remarkable achievement for a trial done in developing countries. Patients were on VKA.
And why do you think there were these different rates of adherence to the drugs across groups?
I don't know.
Okay.
We don't know. Frankly,
Not
we
any
don't know.
adverse effects or
No.
intolerance?
One thing that could have contributed, it did contribute to a little bit of that, is that these were sick patients. They went on to have valve replacement surgeries with mechanical valves during the course of the study. So about a third of patients who discontinued rivaroxaban permanently did so because they had to get mechanical valves.
So they crossed over.
Yeah, so that accounts for about a third of these patients. But the remaining patients, most of it was patient decision why they stopped. And before we go on, I just need to also mention that the INR control in the VKA arm at baseline was as expected, about 30%, 33%. That is, the proportion of INRs in range at baseline was about 33%.
So TTR.
So we looked at the proportion of INRs in range. So
Okay.
that was about 33%, which was expected. That's usual practice, like I said in the beginning. But over the course of the study, by the end of 2 years, we had reached proportion of INRs in the range of 65%. And that was maintained throughout the study. And so this is in sync with all the DOAC trials which were done in high-income countries. So we did a good job with INR monitoring as well.
Fantastic. And your analytic plan was intention to treat
Yes.
as a primary analysis.
Yeah.
And so tell us what the results were.
So at the end of 3.1 years of follow-up, the primary outcome occurred 25% more frequently in the rivaroxaban arm than in the VKA arm. So the hazard ratio was 1.25 with fairly tight confidence intervals and a very low p-value. So this was a very surprising result for us. And for those who will read the paper in the New England, so the curves, the Kaplan-Meier curves actually crossed over. So proportional hazards assumption was not met. So as a result, we had to do a restricted mean survival time analysis. Basically, the restricted mean survival time gives us the cumulative time till the primary event occurs. So the difference in the restricted mean survival time is a good way to analyze when the curves cross over, when the proportional hazards assumption is not met. So by all accounts, this was a statistically significant robust result. So there was a 25% increase in the risk of the primary outcome in patients on rivaroxaban when compared to those on VKA. And most of this, I would like to say it the other way. So VKA reduced the rate of the primary outcome among patients with rheumatic AF because the overall event rates were similar to our previous experience with rheumatic heart disease patients in the ballpark of 8% per year. So that's what we got. So and most of the difference in the primary outcome was driven by death.
Yeah.
And in fact, the overwhelming proportion of the primary outcome was death. So we had over 990 deaths in the study. And that also showed a 25%, 23% increase in the rivaroxaban. So VKA is somehow protected against death.
Fascinating and, as you say, unexpected results.
Very unexpected.
Did you do a sensitivity analysis focusing on those patients that remained adherent to
So we did
rivaroxaban?
an on-treatment analysis, which looks at patients who
Yep.
received at least one dose and in the next 5 days. So we analyzed outcomes. So there was absolutely no difference. It was pretty much consistent. The results remained the same. It was a very robust result.
Okay.
And in terms of the stroke outcome, we had, as expected, fewer stroke events than we had originally planned. The ischemic stroke rates were lower with VKA when compared to rivaroxaban. But overall, the stroke or systemic embolism composite was not different between the two groups. And there was no signal of safety at all. Both the drugs were extremely safe. There were only about 90 odd major bleeding events in the entire study. So, and there was no statistically significant difference between the two groups.
And I suspect that the rates of valve replacement were the same across groups.
Yeah.
Okay. So a large trial, well executed, primarily in low and middle income countries that bear the brunt of the burden of rheumatic heart disease. Tell us about the challenges of implementing a clinical trial in lower resource settings and any particular challenges you had related to the COVID pandemic.
Oh, yeah. So I think here, PHRI is a very experienced group of people who have done these trials in low and middle income countries for a long time now. So they have all the resources and they have the experience and they've done these trials for maybe more than 20 years now. So that's the biggest advantage that we had in terms of experienced people like Dr. Yusuf and Stuart Connolly and others at the PHRI. So that's number one. And the second thing is we had great national leaders across the world, people who were really interested in rheumatic heart disease and who went out of their way to sometimes recruit patients, follow up patients, because some of these countries had local strife and things like that, and they were able to recruit and follow up patients. And COVID didn't help at all.
I'm really glad that we've had a chance to discuss this trial.
It's been a pleasure.
I hope our paths cross again, and I will come to your presentation this week at ESC.
Absolutely.
Thank you for being here.
Thank you.
Hello, my name is Marco Valgimigli. I am a professor of cardiology at the University of the Italian Switzerland and deputy chief of Cardiocentro Ticino Institute in Lugano, Switzerland. Well, I think MASTER DPT is a very important study because, if anything, is the only properly powered randomized controlled studies focusing on HBR patients who have not been selected based on the ischemic risk, namely based on the presentation or the complexity of the intervention they undertook. So in MASTER DPT, we compared a short DAPT regimen versus a more prolonged, let's say, standard DAPT duration. And we presented the first time the primary results last year at ESC, and we showed non-inferiority for NACE and MACE, and superiority for bleeding with respect to lower DAPT being better than prolonged DAPT. Now, this year, we are presenting the final 15 months data, which is in a way showing a confirmatory results of what we showed before. MACE and NACE do not differ, and the difference in major bleeding is even slightly greater in favor of an abbreviated DAPT regimen. There is also another piece of the results which is potentially even more interesting than the main results per se. Namely, after 12 months, we allowed so-called routine care. Basically, patients, irrespective of prior allocation, were allowed to be treated according to the choice and the decision of the treating physician. That is what we call routine care. And when we designed that last phase, we were anticipating all the APT being discontinued in both treatment groups. Surprisingly enough, that was not the case, with a very surprisingly high proportion of patients, especially in the standard DAPT group, still taking DAPT well beyond 1 year, which is completely against the guidelines. We ran multivariable modeling to understand why was the case, and in fact we realized that prior allocation to standard treatment was a major and independent predictor of prolonging DAPT, which is what we called in the presentation carry-over reflex, whereby clinicians in practice tend to simply confirm previous treatment despite this treatment may not be indicated or maybe even harmful. I think the clinical implication of what we are reporting here at ESC is twofold. From one side, you need to go short, and you need to make that provision very clear when you discharge the patient, because if you don't make that provision very clear, nobody would dare to stop the medication. Secondly, we also look into the decision-making with respect to prolonging or not prolonging DAPT, and realize that clinicians are still basing 100% the decision-making on ischemic risk markers. They don't look into the bleeding risk markers, which do impact, as the study does show. I think the future direction is to try to provide simplified algorithm to clearly tell the patient when should DAPT be stopped, depending on the intersection between ischemic and bleeding risk. On the other hand, since we have been shortening DAPT to a very short extent, now 1 month or even lower in patients with oral anticoagulation, I think the next logical question is whether we do need DAPT at all. I think that will be the next set of studies that will come up. So I think a critical step nowadays when we speak about HBR is to come up with a universally accepted definition of HBR. We have based that definition on consensus definition, which was developed by the Academic Research Consortium, which I was very glad to be part of, but that was a consensus, that was basically expressing our opinions. That framework has been, in a way, validated multiple times, and we know that it does work, but it's not perfect. On the other side of the spectrum, we have risk score, which are integrating the coverage in a continuous manner, which may be more precise in telling us the risk. I think the future direction is to try to come up with the algorithm which is merging both strengths of this system to have a universally accepted way of defining HBR.
You can't give what you don't have. And so self-care is the process of filling your tank.
Don't let people bring you down. You just keep working and you lift them up.
It's for the passion that you do the action, and then the results you leave to the destiny of the product.
Ultimately, life is about relationships, and it's important, I think, trying to foster relationships that are fulfilling ones.
I really am the example of an impossible dream, honestly.
Hello everyone, welcome to another episode of Parallax.
And I think looking retrospectively, that was a pure passion. I started medicine thinking that I would become an internal medicine doctor, and I started my internal medicine fellowship. Since the day I was realizing myself that I was more attending cardiology meetings than internal medicine meetings, and at that moment I decided to change. I think it was passion coming from inside, which was not clear since the very beginning, but then it was made clear throughout the first year of exercise and practice. I think everything makes me excited about cardiovascular science in 2022 because we have still big room for improving our patients' care. If we look back into the last 20, 30 years, especially interventional cardiology did huge progresses. Now event rate is really down, and we should not ever leave the boat. We should try to fight to make that event rate very close to zero. That is the aim we should all work for. Hello, my name is Marco Valgimigli. I am a professor of cardiology at the University of the Italian Switzerland and deputy chief of Cardiocentro Ticino Institute in Lugano, Switzerland. So we ask principal investigators of these 7 large randomized control studies to provide us the data, because we wanted to ask a very critical question. Is aspirin monotherapy the way to go forward in terms of secondary and tertiary prevention in patients with established CAD? That was the unique way to gather a huge amount of data. These 7 studies gave us as many as 35,000 patients. Not all of them had established CAD, mainly from the old Capri study, so that group of patients have been excluded. We also excluded patients who had an initial DAPT phase, a part of the study protocol, and then they had either events or died during the APT phase, so we only focus on patients who really started the comparison of aspirin versus P2Y12 inhibitor. And by making this extra selection, the dataset now contains over 25,000 patients who have been allocated either to aspirin or P2Y12 inhibitor, which was either clopidogrel or ticagrelor. Well, we have seen a huge amount of studies giving us the key information that P2Y12 inhibition is central in the prevention of coronary-related adverse events. We discovered the value of that class of drug for stent thrombosis prevention, and nowadays, in the last 10 years, we have realized that P2Y12 inhibitor is central for secondary prevention, irrespective of prior stent implantation. So I think the key question was, is aspirin still as good as P2Y12 inhibitor, or perhaps is aspirin already a relatively old drug which can be replaced by more contemporary agents? So we performed an individual patient data meta-analysis whereby we pre-specified to select all randomized control studies comparing either aspirin or one of the P2Y12 inhibitor in a randomized fashion on centrally adjudicated endpoint. We identified 7 studies for the very old Capri to the most recent OST exam. And actually, these 7 studies are providing data for that amount of patients I was referring to, so more than 25,000 patients, and roughly more than 500 sites recruiting patients in Europe, United States, and South America. So the primary endpoint of the study was a composite of CV death, MI, and stroke, and that was significantly reduced by 12% in favor of P2Y12 inhibitor, with the number needed to treat in the range of 113. We also pre-specified a key safety endpoint, which was any major bleeding. They did not differ from a statistical standpoint, despite numerically were interestingly in favor of P2Y12 inhibitor. However, inside the box of major bleeding, we did see that there were 2 types of major bleeding which were significantly reduced by P2Y12 inhibitor. One being GI bleeding complications, and the other one was almost 70% reduction of intracranial bleeding. So any major bleeding did not differ, but the most common one, GI bleeding, and the most concerning one, intracranial bleeding, were indeed significantly reduced. When we look into other secondary endpoints, stroke did not differ, yet there was a borderline reduction in favor of P2Y12 inhibitor, and there was almost 50% reduction for stent thrombosis favoring P2Y12 inhibitor. I think these findings are really practice changing, and I hope that will be incorporated into new guidelines release. Now, we have been prescribing aspirin with a class recommendation 1A since many years. I think now this is not justifiable anymore. I think we have a slightly better option. Now, you may question the fact that the relative risk difference between aspirin and P2Y12 inhibitor was not huge, it was only 12-13%, yet this extra benefit does not come with any extra cost. The bleeding are, if anything, the same or even lower, at least some type of bleeding. So I think now the new class 1 recommendation should be given to P2Y12 inhibitor more than aspirin, and perhaps leave aspirin as a second line option. I think this evidence is solid enough, but I'm pretty sure that there will be many in the community who will question the results. So I think the next step will be hopefully to do a more contemporary and perhaps very large study comparing again aspirin and P2Y12 inhibitor. Now, we need to understand whether any P2Y12 inhibitor makes any difference. In our study, there was no heterogeneity with respect to the type of, speaking about clopidogrel and ticagrelor. We would need to have data about prasugrel, and I think that will be an extra important question to be answered, which P2Y12 inhibitor to be preferred and in which patient.
You know, I'm a preventive cardiologist, so to me, it's so exciting right now for all the new therapies in cardiovascular disease prevention. And I think that's what's making our field not, you know, so exciting, but also growing so rapidly. We now have tools that we didn't have before. More than just statins, we have new novel medications that can help us lower cholesterol. We also have medications to help our patients with weight loss, which has really been lacking. And these are medications that we know pretty well. We've been using them for diabetes, and yet we found that there's another role for them, that they can assist in weight loss. And I think that's probably one of the most frustrating things in the cardiology field. We understand that people who are obese have a disease. It is a disease. We haven't had a treatment. And we know what we've been saying to patients really doesn't work. Watch what you eat, or, you know, move more, eat less. Believe me, every one of my patients who is obese has tried all of those things. What we haven't had is a way to help the underlying causes of why people overeat, why they can't control what they eat. And these novel medications give us that opportunity. And I think these are real game changers, because we know that, you know, a big portion of our population is either overweight or obese or morbidly obese. Now we can offer them something and really change their risk for the future. And I think over time, as we learn these medications and use them, these are really going to help us. I think also, you know, I do a lot of work on women and cardiovascular disease, and I think the exciting things that are happening in this field is, first of all, we're studying women, and second of all, we're learning a lot about the sex differences between men and women, and that's going to help us really have precision therapy, knowing what works in a woman versus what works in a man. We need that information, and so I think that this is a time that we are really changing how we care for both men and women. When I was in medical school, I remember a very famous cardiologist coming to Canada and speaking at my medical school. She came from the US. Her name is Dr. Nanette Wanger, and she's really the mother of cardiovascular disease in women. And when I met her all those years ago, I remember her pointing out, and I didn't know this at the time, she said, you know, we really haven't studied women. And I think I was slightly shocked to hear that. And being a woman, that just, like, why would I be excluded, or why would people like me be excluded? And hearing about all the differences from her in that moment, I remember saying, I know what I'm going to do. I wanted to be a cardiologist already, but I'm like, I'm going to study women. I'm going to be part of curing this problem. I'm going to study them. And I'm in a very fortunate position to not just be doing what I said back many years ago, but to almost exclusively care for women. I think you know, for any of the young people thinking about a career in cardiology, it is something that's so rapid-pacedly and changing every moment. Not just in terms of new medications, new therapeutics. We put in devices, we do procedures. We have the best of the surgical world and the best of the diagnostic world in cardiology. And I think that it is such an exciting field. I think we also have a very strong community of women in cardiology, and also men who raise us, the he for she's, as we call them. And I hope that people recognize that this field needs more women and needs more of us here at the table, doing research, caring for our patients, teaching the next generation. And I hope that other women will find what I found, what's, you know, gives me the spark every day to wake up and go to work. Hi there, my name is Dr. Martha Galati. I am a cardiologist, a preventive cardiologist, the director of cardiovascular disease prevention at Cedars-Sinai in Los Angeles, and I'm the president of the American Society for Preventive Cardiology. My highlights, surprise, surprise, at this meeting are prevention trials. The first trial that I wanted to highlight is the TIME trial. And this was a trial looking at the timing of hypertensive medications. They compared whether giving medications in the morning or medications in the night, what was the ultimate outcome? Did you do better by one or the other? And it's important for us to want this trial because we've had some data supporting that perhaps taking medication at nighttime might be better. We certainly know that nocturnal blood pressure elevations are actually quite dangerous and actually maybe more predictive of adverse outcomes. This trial, though, showed that there was no difference in terms of the primary outcome if medications were taken in the morning or in the night. So what does that mean for clinical practice? To me, it means that it doesn't matter when the patient takes the medication. I think they should take it when they would be most compliant with it, and also when they are less likely to have adverse side effects. Some patients tell me that they're less likely to have problems if they take the medications at night, and so they should take it at nighttime. For other patients, they might not remember it at nighttime, but they'll only remember it in the morning. And I think this trial was a really important trial for us to have here at the European Society of Cardiology. The next trial that I think was important and was a positive trial was the SECURE trial. SECURE was looking at a polypill. And, you know, we've been talking about polypills now for a number of years for their ease of use. You know, for patients after myocardial infarction, they're often given a number of prescriptions, and remembering them and taking them, adhering to the medications is not really great. We know after a myocardial infarction, only about 50% will continue taking their medications on a regular basis 1 year out. So this trial was looking at would the polypill increase adherence, but also what did it mean for cardiovascular outcomes? Well, what they found is that when they compared the polypill to usual care, the polypill patients were much more adherent. Surprisingly, though, more adherence did not translate into improved LDL or improved blood pressure. In fact, the two groups were exactly the same. Nonetheless, they reported a significant difference in cardiovascular outcomes, or the primary endpoint, in the group that was assigned to the polypill. There's been a lot of hypothesis. Is it the pleiotropic effects of statins and ACE inhibitors? Is it the benefit of aspirin, since there was a greater aspirin adherence overall by taking a polypill that reduced the primary endpoint in the polypill arm? I don't know if these results can actually be explained in that way. And I still have a lot more questions for this trial specifically. So I'm not sure how it's going to affect my practice. I think, you know, it was interesting to have a polypill studied in Europe rather than in the developing world. I think in the United States, it actually has even more implications for my population in the sense that a polypill, the co-pays that our patients pay for each individual pill can also be a barrier to adherence. But overall, our biggest issue for our patients worldwide is adherence to medications. Even after a myocardial infarction, initially, early on, patients are scared. They take all their medications. They do everything that we ask them to do. But over time, we know that changes. So these are important questions, but I'm not sure that it has been answered by this trial. The next trial that I think was very interesting from a prevention standpoint was the DAPA-CAMBA. That study, I mean, first of all, I'll say I was disappointed in the trial in general. I think first off, they didn't enroll any women in this trial, and that is really concerning to me. In this day and age, we shouldn't have trials that exclude women. It doesn't mean that these trial results apply to women at all. We just don't know. But this was a trial of men, and this was doing a type of imaging, looking for coronary artery calcium, looking for aortic disease, also doing blood work, and sort of this mass screening of patients to say, should we be screening everyone in this elderly population in this elderly Danish population. So the trial results were neutral, actually. Although I know it's been spun in many different ways. Of course, their sub-analysis did show that patients under the age of 70 did actually have a benefit of this whole body scanning, if you will, or this whole testing that they did. But overall, in the entire trial, it was a neutral result. I think everyone's going to have a different way of interpreting these results. But I think for now, I would say that right now we don't have evidence for that, for specifically adding in coronary artery calcium and aortic scanning. I think that we need to talk about how our risk scores work. Specifically in this population, using our risk scores probably would have identified high-risk patients. And a lot of the differences that we saw were that the fact that the patients who got treatment did better, but we need to treat patients who are at high risk with appropriate guideline-directed medical therapy. But do we need to do the type of scanning that they did in this study in everyone? Will that improve prevention? I think prevention starts a lot younger. And of course, this wasn't the patient population that they studied. But I think that we need to be studying younger people, starting our prevention therapies earlier. And that will actually help us save more lives.
My name is Gerasimos Philippatos. I'm professor of cardiology at the University of Athens, Greece. As you know, in Fidelio, we investigated cardiovascular kidney endpoints in patients with more advanced chronic kidney disease and diabetes. And in Figaro, we investigated in patients with less severe chronic kidney disease and diabetes in a broader population. I think it is clinically useful to see in a large number of patients with several degrees of chronic kidney disease and diabetes, what is the effect of finerenone versus placebo in patients with chronic kidney disease and diabetes. This is the rationale behind this pooled analysis of Fidelio Figaro, the fidelity analysis. Like in Figaro and Fidelio, patients with chronic kidney disease with a broad spectrum of estimated glomerular filtration rate and UACR have been randomized in the trial, a very broad spectrum, and these patients were on optimal therapy with ACE inhibitors or ARBs. Patients with heart failure with reduced ejection fraction have been excluded from the trial because have an indication 1A for an MRA. Despite the fact that most of the colleagues who see this know already the primary results of Fidelity, let me just repeat it that we've seen in Fidelity an improvement in cardiovascular and kidney outcomes in these patients with chronic kidney disease and diabetes. We know that in this group of patients there is an increased risk of mortality, and cardiovascular mortality is the main reason for deaths in these patients. So we thought that it would be interesting and important to investigate the causes of death in the population of Fidelity. And we confirmed in this large number of patients, more than 13,000, that cardiovascular mortality was the main cause of mortality. The other important causes of mortality were cancer and infection, but the numbers of deaths in these two groups were similar between finerenone and placebo, and we had a very low number of renal deaths in the whole population. What we found is that in on-treatment analysis, there was an 18% decrease in all-cause cardiovascular mortality in patients who were on finerenone compared to placebo, and there was a 25% decrease in sudden cardiac death. As you remember, in the primary analysis of fidelity, we have seen a decrease in the number of deaths in cardiovascular and total mortality, and we thought that it's worth seeing to analyze more, investigate more the details of this and the cause of this mortality. I think that it's clear now, and because we are in a cardiology congress, that a broad spectrum of patients with chronic kidney disease and diabetes should receive finerenone. Until now, in chronic kidney disease patients with diabetes, we had only ACE or ARBs. Recently, SGLT2 inhibition has been added, and now we have finerenone. So I think that in the majority of patients with chronic kidney disease and diabetes, we go like we are going in heart failure with more than one therapies. And I think that this is good for the patients with chronic kidney disease and diabetes. I think that what we don't know is what is the effect of combination of the above mentioned therapies, but in finerenone, in the Fidelio and Figaro, in the fidelity analysis, we have subgroup of patients with SGLT2 inhibitors and GLP-1 arrays, and we have seen, despite the small number, we've seen at least similar results from the combination of these therapies. So I think the way to go, as I said before, is to combine therapies for better protection of these patients with chronic kidney disease and diabetes.
You can't give what you don't have. And so self-care is the process of filling your tank.
Don't let people bring you down. You just keep working and you lift them up.
It's for the passion that you do the action, and then the results you leave to the destiny of the product.
Ultimately, life is about relationships, and it's important, I think, trying to foster relationships that are fulfilling ones.
I really am the example of an impossible dream, honestly.
Hello everyone, welcome to another episode of Parallax.
So I think cardiovascular science, there's a lot more to discover about how we can optimize treatment for patients with cardiovascular issues. I think prevention is the key thing for the future. We want to prevent people having the outcomes in the first place. Now, some of that is lifestyle, but some of that is pharmacological management. And in my own field, I try and prevent the outcomes before they happen by treating people's blood pressure well and treating lipid issues and giving lifestyle advice. So cardiovascular medicine and research is a really exciting field. There's so many different avenues you can explore. A lot of people have said to me since my hotline and presentation at ESC that it's so nice to see a female presenting as the chief investigator of a large randomized trial. And I would totally encourage other young investigators out there, male and female, to do this sort of thing, because you can really make differences to patients' management. And running a clinical trial, as well as being very hard work, is a lot of fun. And it's incredibly satisfying to reach the end of a 10-year project and get an outcome that you can be completely confident in and that will inform practice. So go for it. I'm Professor Isla Mackenzie, and I'm Professor of Cardiovascular Medicine at the University of Dundee in Scotland. So allopurinol is a xanthine oxidase inhibitor, and we normally use it in patients with gout to lower their uric acid levels and to try to prevent acute gout flares. But for many years, the question has been around as to whether it might have additional benefits in cardiovascular disease. So various small studies over the years have suggested it improves certain cardiovascular parameters, but until now, there's never been a large outcome study like ALL-HEART. So the ALL-HEART study was a large prospective, randomized, open-label, blinded endpoint or probe trial. It was a multi-centre trial done across the UK, so in Scotland and England, in 424 general practices. We didn't include patients with severe renal impairment. We didn't include patients with class 3 or 4 heart failure. And patients in the study were all aged over 60 with ischemic heart disease. We also excluded anyone with a history of gout and anyone who was already on urate-lowering therapy. So the study randomized patients with ischemic heart disease to receive allopurinol 600 milligrams daily or usual care. And what we found was there was actually no difference in the primary outcome, which was non-fatal MI, non-fatal stroke or cardiovascular death. There was no difference between the allopurinol arm and the usual care arm of the study. We also found no difference in the range of secondary outcomes we had, so MI, stroke, cardiovascular death, all-cause mortality and various other cardiovascular outcomes. None of them showed a difference. So it was a definitively negative trial. So I think that we have answered the question of whether patients with ischemic heart disease should be given allopurinol to try and prevent future cardiovascular outcomes. And I think definitively we've said no. And that's important because there have been individual patients and doctors around who have thought that that might be the case, that maybe they would benefit from the treatment. We haven't specifically looked at hyperuricemia, but that's another area where it's unanswered, whether they have any benefit in asymptomatic hyperuricemia. So I think at the moment, the only benefit that we know of is for patients who have gout.
I love this discipline because it is very scientific, right? And therefore lots of pathophysiology behind it. It is also, and this is really, really very important, and our colleagues from cardiology need to be proud of this, very much evidence-based. The level of evidence-based guidelines in cardiology are much larger than any other discipline. You can walk through to your other colleagues in the hospital and find out about nephrology, pneumology. How many of their guidelines are hard evidence-based? So clinical trial discipline has been contributed very much to the cardiology. And of course, it's the heart, right? So we have the behavior and the human part of cardiology. This is our fathers, our mothers, and certainly the elderly among us. So caring for these patients is really important. So this is a combination of human factor of science and clinical trial. Yeah, well, this is typically indeed the science-driven discipline. Cardiology has always been, at least in my career, science-driven. And as a matter of fact, in addition to my MD and cardiology specialty, I am a PhD in clinical pharmacology. And this is what opened up my mind and the doors in developing interest in drug therapy, but also in clinical trials. So this is the combination which I find very exciting. I'm Fayez Zinad. I'm a heart failure specialist and emeritus professor of therapeutics and cardiology in University of Lorraine, and have been active mostly in the clinical trial field as a clinical trialist. Well, the Emperor pooled is basically pooling the data from Emperor preserved and Emperor reduced. And the big question mark after we have shown that this class of drug is effective in heart failure is, why is that so? Because these drugs were developed to start with as glucose-lowering medication, but then we have shown that in Emperor, the drug works equally in non-diabetes and diabetes. So it must be something different. And we have a clue from basic science, from molecular biology, on potential mechanism of action, but not being verified in the clinical setting. And it is a huge opportunity to have clinical trial data, controlled, randomized, placebo-controlled, with different time points to analyze biomarkers. Now, we have elected to use the proteomic approach because proteins are mostly behind the mechanism of action of medication and they are targets of drugs. And we have used a big screen called proteomic, whereby we can measure hundreds of proteins at once, selected, so it's not totally unbiased, but it is semi-biased, selected to a word cardiac and renal pathophysiology. And the bottom line is that we did reproduce what has been shown in basic science and find few more mechanisms of action which were untapped so far. So the two main messages is that the mechanisms of benefit in heart failure, benefit cardiac and renal, are not necessarily related to glucose lowering or metabolism effect, but they are related to mitigation of inflammation, of fibrosis in the heart, in the kidney, but also of autophagy. Autophagy is a mechanism very familiar to oncologists. And this is potentially new in the cardiovascular field. And it is kind of a house cleaning process whereby the debris and the cells which are not doing well can be cleared, right? So there is a stimulation of autophagy in order to help with the remodeling of the heart and of the kidney. So there are multiple other mechanisms. So there are a pleiotropic mechanism of action, not necessarily related to glucose lowering, and autophagy, inflammation, and fibrosis are the key words. There are a few other mechanisms, but that's really new. And my final word is explaining how clinical trial can contribute to mechanistic science. Usually we only rely on experimental, basic animal studies, but here this is what typically we call reverse translational, from bed to bench, right? And therefore, with these omics, and we have started the proteomic, we hope we'll have a journey through other omics, there is a way from clinical data to uncover the mechanism of action of drugs and the mechanism of benefit, this case in the heart and the kidney. Well, this is a very meaningful step because there haven't been so many exploration of mechanisms of drugs in the clinical setting. We did so explaining the mechanism of action of a mineralocorticoid receptor antagonist, spironolactone, in the HOMAGE trial. So these are the very few first elements, and I'm pretty sure that this is going to be opening, very, very importantly, the investigation of mechanism of action, but because in cardiovascular, most of the time, and we call it serendipity, we find benefits of drugs which were not thought of. And this is typically the case of SGLT2 inhibitors. They're being developed as glucose lowering, and then all of a sudden we find that they may be useful for something else. So this new discipline of omics-based mechanistic study from clinical trial data are going to be really growing.
Associate Professor of Medicine from McMaster University, and I'm absolutely thrilled to have Professor Scott Solomon from Harvard Medical School, who is here to present his late-breaking clinical trial, DELIVER. Welcome, Scott.
Thank you, Harriet.
Why don't you tell us about the knowledge gap that DELIVER will close?
Well, first of all, as you know, there are about 64 million people living with heart failure worldwide, and about half of those people have heart failure with mildly reduced or preserved ejection fraction. We've been so successful in treating heart failure with reduced ejection fraction, but we've been less successful in treating heart failure with mildly reduced and preserved ejection fraction. So we're very excited with these new results in this trial. DELIVER was the largest trial ever done yet in heart failure with mildly reduced and preserved ejection fraction, and really serves to fill in some of the gaps. Even though we had data a year ago at the ESC from EMPEROR Preserve that was fabulous in reducing cardiovascular death and heart failure hospitalization, there are at least 3 groups of patients in which we really have less knowledge about, and these include patients who were recently hospitalized or started in hospital. They're patients with improved ejection fraction, that is those people who started with an LVEF under 40%, that is then improved to over 40%. And also EMPEROR Preserved, as you know, there was a question about attenuation of the treatment benefit at the highest part of the ejection fraction spectrum. And these are all answers that we hope to be able to answer with DELIVER.
Fantastic. And, you know, the broader context is SGLT2 inhibitors have really changed the way heart failure care is delivered, and also given us armamentarium to reduce the incidence of heart failure. And this is a specific knowledge gap that no trial has ever tackled. So a first-of-a-kind clinical trial that involves mildly reduced ejection fraction, improved ejection fraction in patients who are newly initiated following hospitalization. Tell us about the trial methods and the eligibility criteria.
Yeah, so we enrolled patients who had New York Heart Association class 2 to 4 heart failure, left ventricular ejection fraction over 40%, but that could include people who had previously had a lower ejection fraction so long as it had improved. Patients had to have elevation in natriuretic peptides, and they had to have evidence of structural heart disease as well. They could be enrolled either in the ambulatory setting, in hospital, or shortly after hospitalization. We randomized patients to dapagliflozin 10 milligrams or placebo. We ultimately randomized 6,263 patients. It was an event-driven trial, and we followed patients for a median of 2.3 years.
Right, and how many events were you hoping to accrue during that follow-up period?
About 1,100 events.
Okay.
Yeah.
And then tell us about the baseline characteristics of your patients.
Very characteristic of our heart failure with mildly reduced and preserved ejection fraction population. We had an average age of about 72, 44% were women. We had a mean ejection fraction of 54%. The mean GFR was 60. The majority, about 70% of patients, were New York Heart Association class 2. Patients were on the sort of typical medications that we see in this population, including diuretics. 70% were on loop diuretics. About 85% were on ACE inhibitors, ARBs, or sacubitril/valsartan. 80% on beta blockers, and a very high percentage on mineralocorticoid receptor antagonists, 42%.
And what proportion of participants had improved ejection fraction?
18%, which is the first time that these patients have actually been allowed in a clinical trial in heart failure. They were excluded from all other trials.
And what proportion had mildly reduced ejection fraction?
About 70% had an EF that was below 60%, and probably about 40% had an EF that was between 40 and 50%.
Fantastic. So tell us the trial results. We haven't heard them before because you've yet to present them, so I get to hear them before anyone else.
Well, you do get to hear them before anyone else, and very exciting. We saw an 18% reduction in the overall treatment benefit for the primary composite endpoint, which was a composite of cardiovascular death and worsening heart failure. Worsening heart failure consisted of both heart failure hospitalization and an urgent heart failure visit. And we saw that in our patients overall. We saw that in patients with an EF that was over 60% and very consistent results across the ejection fraction spectrum. No evidence of heterogeneity or even a hint of attenuation as ejection fraction went up. So that was the primary result. We saw a 21% reduction in heart failure hospitalization and a 12% non-significant reduction in cardiovascular death. We saw a significant reduction in total heart failure events and cardiovascular deaths, not just the first, but the recurrent events. And we saw a 2.4 point improvement in the Kansas City Cardiomyopathy Questionnaire total symptom score, a measure of symptom burden that was highly statistically significant. And no matter how you look at it, if you look at 5-point improvement, 10-point improvement, 15-point improvement, you're more likely to have that in the dapagliflozin arm than in the placebo arm.
Remarkable how the treatment effect was consistent with Emperor Preserved in that the size of effect was similar and the component outcomes were similar, the effect on the component outcomes. Yes. Did you have a large enough event rate for cardiovascular death that you could be certain as much as you can with regards to treatment effect on a component endpoint?
No, it's a very important question because cardiovascular death, as you know, is less common. The rate of cardiovascular death is about half in patients with heart failure with mildly reduced and preserved ejection fraction as they are in heart failure with reduced ejection fraction. In this trial, it was exactly half as it was in DAPA-HF. So we didn't have the power to answer that question. Now, you will see additional data when we pool together the DAPA-HF and DELIVER trial. You'll see additional data where we've pooled together in a meta-analysis Emperor Preserve and DELIVER. And there you can see that with more power, with more events, we really do believe there is an effect on cardiovascular death, but these trials are individually too small to show that.
Right, so in that pooled analysis, was there a significant treatment effect on the endpoint of cardiovascular death?
Yes, a very significant treatment effect across the spectrum with no hint of heterogeneity. In other words, the treatment effect was the same from the lowest EFs in DAPA-HF to the highest EFs in DELIVER. And that tells us that this is a therapy that probably does work similarly no matter where you are in the heart failure spectrum.
Right, and heart failure hospitalization has a tremendous burden on our healthcare system. So it's a very relevant endpoint to show treatment effect in. Can you comment on effect on all-cause death?
Yeah, so interestingly, the hazard ratio for all-cause death was 0.94, so, and it was not statistically significant. Remember, these drugs don't have an effect on non-cardiovascular death. We also had a lot of COVID in this trial. We had close to 600 patients who were diagnosed with COVID during the course of DELIVER, 155 deaths that were ascribed to COVID during the course of DELIVER, and those are all non-cardiovascular deaths and not really modifiable by a therapy like this. And in fact, when we censor the patients at the time of COVID diagnosis, we even see a stronger effect for all-cause mortality because you get rid of all those COVID deaths. The other point I want to make is that we saw consistent results in the patients who were recently hospitalized, and we saw consistent results in that group of patients with heart failure with improved ejection fraction. And we're very excited, of course, about that because this is a group of patients that we didn't have a lot of data for.
Can you comment on renal endpoints at all?
Yeah, so we didn't in DELIVER collect renal endpoints in the way that many of the other trials did. So what we can say is that the renal adverse events were about similar in the two groups. We will be presenting more detailed data at the American Society of Nephrology about the GFR slopes, and we're excited to share some of those data as well, but we won't be presenting those at the ESC.
Right, a lot of secondary publications and subgroup analyses, but the big take-home point is that dapagliflozin has a large treatment effect on the composite endpoint of heart failure events and cardiovascular death among patients with mildly reduced ejection fraction, preserved ejection fraction, and improved ejection fraction, with pooled estimates from 2 large trials showing that there is also a treatment effect on cardiovascular death among SGLT2 inhibitors. Thank you so much for joining me today, Scott. I'm so excited about your presentation, and I can't wait to see you on the big stage.
Real pleasure, Harriet.
Well, I'm a respiratory physician, but I did notice that when I was younger, I was getting a lot of patients referred who had heart disease, and we noticed they have a very high prevalence of sleep apnea, much higher than the otherwise healthy population. So, for example, patients with heart failure have about a 40 to 50% prevalence of sleep apnea compared to about 5 or 10% in the otherwise healthy population. So that got me excited, making me wonder, you know, maybe the sleep apnea is having an adverse effect. And it turns out it does have adverse effects, and independent studies, prospective epidemiologic studies show that sleep apnea is a risk factor for hypertension, stroke, and heart failure, and to a lesser extent coronary disease. So that got me excited and started me in the field of looking at the physiology of how sleep apnea interacted with heart disease and how treating it might improve outcomes. And that's kept me going for the last 35 years. And so making observations in a field like medicine and following them up gets me excited. And I can tell you, in the 35 years I've been working as in the medical field, my area, I've never had a single dull day, not one. And the other thing that gets me excited is getting young people involved in the research and seeing them grow up and do well. So many of my fellows, I've had 42 of them, are now heads of their departments. They're doing research in the area as well, and this makes me get out of bed in the morning. Well, first of all, you've got to be prepared to do a lot of hard work. This is not a 9-to-5 job. You will not discover major things by working 40 hours a week, number one. Number two, don't pursue things unless you're really committed to it and you get excited about it, because it can be very frustrating if you're not. you have to have a passion for this sort of thing. What I mean by that is in medical research, right? To me, doing medical research and getting paid for it is like sending a kid into a candy shop, because you get paid to do what you love to do, right? And to me, that's a luxury. The vast majority of people don't have jobs like that. So medicine is a fantastic field. Medical research is even more fantastic. So for young people wanting to get interested in this field, get interested in it with a passion, because if you do, it can be the most exciting career you can have. So my name is Dr. Douglas Bradley. I'm a professor of medicine at the University of Toronto. I'm the former director of the Division of Respirology for the University of Toronto. I also run the sleep medicine programs at the University Health Network in Toronto. Well, prior to the trial that I just presented, there was evidence from smaller trials, many of which were done in my laboratory, that treating both obstructive and central sleep apnea improved cardiovascular function by increasing ejection fraction, reducing sympathetic nervous system activity, and also there's evidence that it improved exercise tolerance on the 6-minute walking test. So there was a number of physiological factors that improved that would suggest that it might improve mortality and hospitalizations as well. Study device is called adaptive serval ventilation. Basically, it's like a pacemaker. So if you're stop breathing, if you stop breathing, you have a central apnea, the machine will ventilate you, okay? If you don't stop breathing, it just provides a low background pressure but doesn't ventilate you. If you have obstructive sleep apnea, it increases the pressure, the background pressure, but it doesn't ventilate you, but it just raises the pressure enough to keep the airway open. So it treats both central and obstructive sleep apnea. The device we use is made by Philips Respironics, and it's triggered by what's called peak airflow. So that means that it's aiming, if the peak airflow drops below a certain point, it will start to ventilate you or to treat your obstructive sleep apnea, depending upon which type of apnea you have. It's different than the device used in the SERVE trial. The SERVE trial used a device that was triggered by minute ventilation, and it was a more aggressive device with higher background pressures. And in the SERVE-HF trial, which was published in 2015, they found that that ventilator actually caused an increase in mortality, and therefore it's not used for that indication anymore. So that's the device that we use, and it's different from the other one. The study population was men and women, adults, with low ejection fractions, below 45%, with a history of heart failure, who were on stable medication and were stable clinically. So basically that's the population we aimed for, yeah. Key findings were that in 731 patients that we analyzed, the group randomized to the device had a marked reduction in their apnea-hypopnea index, so it completely got rid of their sleep apnea over the entire 5-year course of the trial. And it didn't matter whether they had obstructive or central. It treated both. However, there was no significant difference in the primary endpoint, which was the combination of cardiovascular hospitalizations, death from any cause, atrial fibrillation, new onset atrial fibrillation, and ICD discharges. There was no significant difference between the two groups. And it didn't matter whether they had obstructive or central. It didn't make any difference. On the other hand, it didn't cause any harm, so it's unlike SERVE, in which patients actually had a higher mortality. In our trial, they didn't. If we looked at mortality alone, there was no significant difference, again, between the two groups, either obstructive or central or the whole group. On the other hand, in the central group, we had fewer patients than we had anticipated, because in 2015, when the SERVE trial results were published, regulatory authorities in Germany and France disallowed enrollment of patients with central sleep apnea, despite the fact our Data and Safety Monitoring Committee had seen no safety signal at all. So they overruled our Data and Safety Monitoring Committee. So there's a major ethical problem here. And as a result, instead of getting 430 patients with central apnea, we only got 198. In that group, there was a trend towards a lower mortality. The hazard ratio was 0.78, which means a 22% reduction in mortality rate, but the p-value was 0.34, so it wasn't significant. On the other hand, that difference between the two groups is a difference we predicted when we created the sample size. So the conclusion then would be that there's no indication to treat, the other point was the patients with obstructive apnea had to be non-sleepy, because if they were sleepy, they would have an indication to be treated. So in non-sleepy patients with OSA, there's no indication for them to be treated if they have heart failure, because we don't have any indication that it improves their outcomes. In the central apneics, there's a trend towards improvement, but not significant. So there's no indication, therefore, to treat them either. However, the quality of life data have yet to come out, and if the quality of life data show an improvement, and we've shown that the device is safe, then there may be an indication to treat people who have bad heart failure that's relatively refractory to drug and device therapy. I don't, at the moment, with the fundings we have, I don't think it will have a big impact, except that cardiologists will be more reluctant to send patients for sleep studies because we don't have any evidence that treating the non-symptomatic patients with obstructive sleep apnea does any good. Similarly with the central apnea, again, depending upon what the quality of life data show, I don't think it's going to have a major impact there either. The major impact is that we do show that there's no harm, but we also show that there's no statistically significant difference in the major outcomes. Well, in the central apneics with the device we used, again, there's a signal there, it's just not significant. The problem is funding these trials, right? So these trials are funded, in this case, by Philips Respironics and by our Canadian Institutes of Health Research by a peer-reviewed grant. But we don't have the kind of money that pharmaceutical firms have. And so it's very difficult for us to do studies with thousands of patients because we just don't have the money. If I had the money, I would have extended the trial in the central apneics because we still have equipoise there. And you know, if we got 400 or 500 patients, we might see a difference. So if somebody wants to do it, I'm near retirement, so it's not going to be me. But there is a signal there, and if somebody wants to follow that up, they should do that. But I suspect they're going to have a hard time getting funding for it.
I'm Harriet Vanswell, Associate Professor of Medicine and Cardiologist from McMaster University in Canada, and I'm delighted to have with me Professor Devaka Pereira from King's College London. He's a principal investigator of the revived BESIS trial, and we are here at ESC 2022 to discuss his hotline presentation. Welcome.
Harriet, thank you very much. It's a real pleasure to be able to share the results with you and to perhaps discuss it in a bit more detail. So revived BESIS 2 was the first randomized controlled trial of percutaneous coronary intervention versus optimal medical therapy for patients with severe ischemic left ventricular dysfunction. Now, in the trial, we defined ischemic left ventricular dysfunction as those patients who, firstly, had very severe left ventricular impairment, an ejection fraction less than 35%, extensive coronary disease, which we quantified using the British Cardiovascular Intervention Society jeopardy score. That's a score which has a maximum value of 12, which means that all myocardial territories are supplied via diseased coronary arteries, and the minimum score needed to get in the trial was 6. And also the third criterion, which was that there needed to be demonstrable viability in the territories that were being revascularized. So at least 4 segments that you were planning to revascularize had to be dysfunctional at rest and then shown to be viable on cardiac MRI, SPECT, PET, or other modalities.
Why did you choose to include viability as an eligibility criteria? One would tend to guess it would favor intervention, but on the background of the STITCH trial, it did not demonstrate an association between viability and outcomes. Why did you choose to retain it?
Well, as you said, we'd expect viability, inclusion of a viability criterion to favor intervention, and that's really how the entire trial was designed. If there was a benefit of PCI at all, it would be in this group, and we wanted to focus the trial on this group. And conversely, if we didn't show it in this group, it's highly unlikely that there was going to be a benefit. Now, we probably don't have time to talk about the differences in which viability was used and assessed in STITCH and in Revived, but very briefly, in the viability sub-study of STITCH, it was used as a yes-no. A binary, yes, the heart or the patient has sufficient valvular myocardium or not. And then the surgeons did what they could and grafted everything. With PCI, as you and I know, we use it in a much more targeted and regional way. So it actually informed the strategy of PCI. So it's vastly different context. But we thought we were, if you like, stacking the decks in favor of intervention. And if it were positive, then we'd look at less likely groups. But if it wasn't positive, we'd have a definitive result. So that's why the trial was designed that way.
Importantly, the patients had stable coronary artery disease and did not have established heart failure.
Well, they had stable coronary artery disease, yes, but they were also stable from a heart failure perspective. So we didn't take patients who'd been admitted with decompensated heart failure, because what we didn't want was to judge an ejection fraction to be below 35% when he was just stunned or recovering from a recent event. So recent ACSs were excluded up to a month afterwards, and also recent hemodynamic instability. So these are stable patients who are stable from a coronary perspective, but also a left ventricular perspective. But they weren't patients who'd never had heart failure symptoms. 1/3 of our patients who we enrolled actually had a heart failure hospitalization within the prior 2 years. It's just that good medical therapy had been instituted so that at the time of randomization, they were in a stable phase.
Tell us about the trial methods.
Yeah, so it was a 1-to-1 randomization, open label, of course, with this kind of trial. And we started off with 700 patients and ended up randomizing them to roughly equal groups, 347 in the group that had PCI and 353 in the group randomized to have optimal medical therapy. Minimum follow-up was for 2 years, but of course we carried out the trial over a 10-year period, including the follow-up interval. So some patients had follow-up for up to 8.5 years. The primary outcome event was all-cause death or hospitalization for heart failure.
I love that primary outcome. It's relevant and it's not tailored to the intervention, but tell us why you chose all-cause rather than cardiovascular death as one of the components.
Yeah, no, that's a good question. Of course, we did look at cardiovascular mortality, but that was a secondary outcome. I think that with the best clinical events committees around, adjudication of cardiovascular mortality is still subjective to an extent. So the most robust outcome that we can collect is all-cause mortality. And in the UK in particular, we have the benefit of a really good centralized records system so that you can track mortality absolutely accurately, all-cause mortality. But when it comes to cause of death, it's a little bit more subjective. So we wanted something that was absolutely clear-cut, with no subjectivity involved. So that's the mortality component. And as you said, heart failure hospitalization is actually a patient-centric outcome that we need to include, not repeat revascularization and all of the other outcome components that are often included, which are really physician, interventional cardiologist-centric, you might even say. So that was our key, that was our primary outcome, but we had key secondary outcomes as well. And the first of those was a mechanistic outcome, left ventricular ejection fraction. Because when we believe we do good for patients, it's often mediated, we think, by an improvement in left ventricular function. So we assessed LV function at 6 months and at 12 months. And then back to patient-centric outcomes, how did they feel? It doesn't matter what we do if their quality of life is poor. So quality of life metrics like the Kansas City Cardiomyopathy Questionnaire were pre-specified major secondary outcomes.
Tell us about the baseline characteristics of your patients.
Right. So we enrolled an older population than most trials of poor left ventricular function, and definitely older than ischemic cardiomyopathy trials like STITCH, so 70 years, the median. So half our patients are older than 70 years, which actually is quite unusual for this kind of trial. They had a mean LV ejection fraction of 27%. So we achieved what we wanted to do in terms of severe LV dysfunction.
And that was established through what modality?
So entry could be by echocardiography or cardiac MRI. Those are the two modalities. And a lot of coronary disease. So remember I said that the minimum BCIS jeopardy score needed to be 6. The median BCIS jeopardy score was 10. So these are patients with a lot of coronary disease. And we didn't exclude patients with left main coronary disease. So nearly 100 patients had critical left main coronary disease as well as poor left ventricular function, and we randomized them to medical therapy or revascularization, which I believe is a first amongst RCTs.
What was the uptake of medical therapies in the control group?
Really good, actually, in both groups. So if we look at the major indicators, if you look at ACE inhibition, angiotensin receptor blockade, or ARNIs, about 90% were on one of those drugs. About 90% were on a beta blocker, and around 50% were on a mineralocorticoid receptor antagonist. But in addition to the tablet, the pharmacotherapy, the device therapy was also pretty impressive. About a quarter of patients had an ICD with or without resynchronization therapy at baseline. And if you look, we pre-specified that we'd look for an interval of 90 days from randomization. By then, a much greater proportion. So I think this was, even our heart failure colleagues would be happy it was a properly medicated, well-managed group.
And you had heart failure cardiologists involved in the care of these patients.
Very much so. So every center had two leads, a PCI lead and a heart failure lead, and that was mandatory for the trial design. And they were informed directly by a central medical therapy committee who reviewed all of the guidelines as we went. We anticipated that there'd be lots of changes, and boy, were there lots of changes. At the start of the trial, no one had even heard of an ARNI. Then came along Paradigm, and by the end of the trial, SGLT2 inhibitors. So it was a moving field, and actually the medical therapy committee were excellent. They were able to translate those results directly, pass it on to our centers, and get the patients on individually appropriate therapy.
So tell us about your treatment effect on the primary composite endpoints, the component endpoints, and the secondary endpoints.
So the primary outcome in the medical therapy group happened in 38% of patients at a median of 3.4 years, which is really quite astonishing. 38% had either died or had an admission with severe heart failure. And it was almost exactly the same in the PCI arm. All the way through trial follow-up, the event curves really tracked each other. There was no divergence. And actually, this is obviously the main result is that there was no reduction in all-cause death or heart failure hospitalization. But also, we saw that PCI is a very different treatment to CABG. Unlike the STITCH trial, there was no excess of mortality with the then divergence in the opposite direction later on. Not at all. It's just completely overlaid.
Right, but overall consistent with STITCH in that there was no benefit to revascularization in these high-risk patients.
Correct.
And also consistent with other PCI trials in the stable coronary artery disease population.
Very much so. Bang on. What we would, ischemia, courage, all of those trials had excluded patients with LV dysfunction. We've now shown what they found is true even of patients with severe LV dysfunction.
Absolutely. And perhaps also that our current era of guideline-directed medical therapies that have come a long way potentially had an impact on the overall event rates.
Yeah, yes, they did, but I still think we haven't cracked the problem, because if 38% die or are admitted with severe heart failure, that's not a problem solved in my mind.
No, absolutely not.
Big advances have been made, but we still really need to try and hone in. It may not be that doing PCI is the right thing, but then we need to search for other therapies or try and look for groups that benefit. Now, you asked about the components. Actually, the major driver of this composite outcome was mortality and not heart failure hospitalization. There were 2 deaths to every first heart failure hospitalization. So it was really driven by mortality.
And the big picture is that to tackle this burden, we ought to prevent it through management of risk factors and primordial prevention of risk factors, I would say. But really no benefit to invasive care in patients with stable coronary artery disease, regardless of viability in those with impaired LV systolic function. Tell us about the patient-reported outcomes.
Yeah, that was interesting. So the Kansas City Cardiomyopathy Questionnaire did improve much more in the PCI group than in the medical therapy group at first. So 6 months, 12 months, there was a clear separation of curves and a clinically meaningful gain in quality of life. But as you went on further and got out to 2 years, you saw that the difference had diminished. Now, it had diminished not because the PCI patient's quality of life dropped, but because the medical therapy arm gradually caught up, which again speaks to good medical therapy working for quality of life as well as prognosis, really. And that was mirrored in all of the quality of life metrics we used, EQ5D5L, NYHA class, all of those absolutely told us the same story.
Okay. If you had to redesign this trial, what would you change?
Wow. Right now, I'm not feeling like we needed to redesign it necessarily, but I think that there's still a lot of data we have collected, a wealth of information, which we haven't yet paid justice to. So we need to delve more, look at the coronary details more, the revascularization details more, viability. Now, we brushed over left ventricular ejection fraction. There was no difference in the two groups. But this is a global metric. When we have very regional, we've done segmental analysis by a blinded core lab. We have 500 cardiac MRIs done in this cohort, which is the largest collection of cardiac MRIs in an ischemic cardiomyopathy cohort. So there's, and also ICD data. We know what happened to those patients who didn't die, but we will know. The data are there locked in our databases, which we need to pull out. So aborted sudden deaths. So there's still a lot to come. So rather than, I haven't yet started thinking about redesigning Revive, but I think there's a lot more to come out of Revive than we have yet seen.
Absolutely. Well, let me congratulate you on a well-designed and well-executed trial and your fabulous presentation at ESC. We look forward to more publications to come out of this wonderful work, and I can't wait to see you again.
All right. Thank you very much.
My name is Mandeep Mehra. I'm a professor of medicine at Harvard Medical School and the Distinguished William Harvey Chair in Advanced Cardiovascular Medicine at the Brigham and Women's Hospital in Boston, Massachusetts. Momentum 3 is the largest trial looking at comparative effectiveness of two left ventricular assist devices, the HeartMate 3, which is a novel, fully magnetically levitated pump, and the HeartMate 2, an axial flow pump, an older generation pump. These are pumps designed for use in patients with advanced heart failure, those who are escaping the effects of benefit from pharmacological therapy, most of whom are bound or nearly bound to IV inotropic support or maintain a functional status at home that is naturally bed-bound to some extent. This trial was originally started in 2015, and the 2-year follow-up of this trial, which was considered to be its complete follow-up, was concluded in 2018 with the final report provided in 2019. As a condition of approval of the HeartMate 3 pump, the US FDA mandated a 5-year follow-up of this particular trial. And the current analysis is really outlining the outcomes at 5 years for this trial. The device itself, the HeartMate 3, is a fully magnetically levitated left ventricular assist device. This is a device that is almost frictionless. It has very wide blood flow paths and is also designed with an intrinsic pulsatility algorithm that prevents stasis within the pump. The engineering of this device was designed to really overcome one of the most vexing dilemmas that we had with left ventricular assist device therapy, which was the notion of hemocompatibility related adverse events. And these included gastrointestinal bleeding, strokes, as well as de novo pump thrombosis, which required reoperation of the pump. This study is a one-to-one randomized study to the fully magnetically levitated, more hemocompatible pump, the HeartMate 3, and the HeartMate 2 axial flow pump. This study included over 1,000 patients who were initially followed to the completion at 2 years, and then the current analysis mandated continued follow-up to 5 years. Of note, at the 2-year reporting, this particular study showed that the HeartMate 3 pump, the fully magnetically levitated pump, was superior to the axial flow pump on indices of hemocompatibility-related adverse events, including near elimination of pump rethrombosis requiring reoperation, a halving of stroke rates, and a third reduction in gastrointestinal bleeding. What was not shown, however, at the 2-year mark was a difference in survival between the two pumps, and that really left a question in the field as to whether these changes that we've seen in terms of morbidity translated into long-term outcomes. At 5 years, we found that the HeartMate 3 fully magnetically levitated pump, in fact, achieves a significant survival benefit. The 5-year survival now is approximately 60% with the HeartMate 3 pump, as compared to 40% with the HeartMate 2 axial flow pump. This actually translates into a median survival benefit with the HeartMate 3 pump that exceeds 5 years of life prolongation, something we have just absolutely not seen with this technology in this very, very sick population of patients. The first point I'd like to make is that not only did we show and confirm a survival benefit at 5 years plus, but we also confirmed the initial superiority on hemocompatibility-related adverse events. And in fact, much of the attribution of reduction in mortality was a result of reduction in hemocompatibility-related cause-specific deaths in this particular trial. That is not to mean that there aren't challenges with the pump technology moving forward. For example, we did not show a difference in heart failure or infection-related deaths in this particular trial, indicating that we do have more opportunity in the field as we move forward. There are complications that can occur with late degeneration of these device components, particularly one of the peripheral components, the outflow graft, can in fact have some constriction or narrowing over time, which results in low flow states, but can be very easily mitigated if diagnosed and surgically or percutaneously interventionally treated. So this is something that clinicians have to stay vigilant for with this particular pump, but this hasn't really resulted in a major negative in terms of its long-term survival. What we're really pleased to note is that for the first time in a population of patients with a median survival that is less than a year, these are IV inotropic therapy bound patients with advanced heart failure who are no longer responding to pharmacological therapy as they should, that we can in fact prolong the lifespan by over 5 years, and that is something not seen in this field before this observation. Yes, we believe very strongly that patients who are transitioning from chronic heart failure, who are very stable on guideline-directed medical therapy, who now are escaping the effects of these guideline-mandated medical therapies or are unable to tolerate this. For example, these are typically patients who are having repetitive hospitalizations. These are patients unable to titrate guideline-directed medical therapy to goal, or we are having to reduce this therapy down in these patients. Are likely candidates for this. Patients who require more and more diuretic therapy in a staircase manner to, in fact, keep them stable are all candidates for this particular therapy. These are classically patients who are nearing the need for IV inotropic therapy use or require IV inotropic therapy use during hospitalizations, but also bed-bound patients, patients who are, in fact, suffering from a very, very poor quality of life with advanced heart failure are all particularly good candidates for this particular treatment option.
I'm here Harriet Vansfall, Associate Professor of Medicine and Cardiologist from Canada, and I'm here with Professor Wilfred Mullins, the Principal Investigator of the ADVOR trial that he is presenting at ESC 2022. Welcome, Professor Mullins.
Thank you. It's a pleasure to be here.
Your trial has generated much excitement, partly because of the burden of heart failure on hospitalizations, healthcare resource utilization, and the issue of decongestion and how persistent congestion is associated with rehospitalizations. So you sought to answer an important clinical question. Tell us what that question was.
Yeah, like you're alluding to, I think the trial was designed in the most difficult area within cardiology to show a positive endpoint. And that's the patient admitted with acute decompensated heart failure. We know that many trials have failed to reach their primary endpoint. So we set up the trial very meticulously in the hope that we could reach a very important clinical endpoint of decongestion. And what we did is we compared the classical therapy, which is a standardized scheme of diuretic therapy with loop diuretics plus placebo, versus the same standardized loop diuretic therapy plus the old drug like you were referring to, acetazolamide. Acetazolamide is a very old diuretic agent that blocks sodium uptake in the proximal parts of the kidney, and we've shown before that that can boost the diuretic efficiency of loop diuretics.
Now tell us how you sought to establish the appropriate loop diuretic dose for the control group.
Yeah, we looked back at the data that was available from other randomized trials, and there's only one, that is the dose trial. And what turned out to be most effective in the dose trial, which we also incorporated in our Heart Failure Association algorithm in Europe, is twice the home dose. So when the patient came in, for example, with 2 milligrams of bumetanide, we gave him 4 milligrams a day. First day, bolus 4 milligrams, and the second day we split the amount in 2 doses.
Okay, and you switched from oral to IV therapies.
Exactly.
Right.
Yeah.
And did you titrate those to urinary sodium or use any objective measures of decongestion in the control group?
So we strongly believe in urinary sodium as an indicator of a diuretic response, but that's too early to adopt in a trial. So what we did is we trained the investigators to do their best job to assess congestion on a volume overload basis. So we trained them to look at edema on the legs, to rule out pleural effusion and ascites. For the latter two, they needed to use technical exams, a chest X-ray or an ultrasound for the pleural effusion, ultrasound of the abdomen for ascites. We also collected urine for the first 2 days. And if the patient did not make enough urine, defined as less than 3.5 liters, in both groups, the physician needed to escalate diuretic therapy. And there were several options to do so.
Okay. So the same dose of IV diuretic in both groups plus acetazolamide in the treatment group.
Exactly.
Okay.
Yeah.
So tell us about your baseline characteristics.
Yeah. Well, they're really real-life patients, you know? They're 78 years of age. Median NT-proBNP was 6,200, GFRs of about 38, with a lot of comorbidities. 60% were male, 40% were female, so also on the gender, we had a good balance. 2/3 were half PEF, and 1/3 was half REF. So this is actually what we're seeing. Our emergency rooms are floating with all these type of patients, elderly with a lot of comorbidities.
Right. And were there any patients that were not represented in this trial, or what were the exclusion criteria for the trial?
I think what is one of the limitations mentioned in the New England Journal is that it was a trial only recruiting patients in Belgium. So that's mostly 99% the Caucasian population. So we cannot extrapolate the data perhaps to other ethnic people, so that might be a limitation. But the main inclusion criteria, it was a pragmatic trial, was straightforward. There was acute decompensated heart failure, volume overload, already on a loop diuretic at home, and NT-proBNP levels above 1,000.
Okay. And you excluded people with very reduced GFR and hypotension.
Yeah, so we excluded patients from which we knew this is not going to be of benefit. So if their GFR was below 20, if they were on pre-cardiogenic shock, defined as a blood pressure below 90 systolic, and we also excluded patients on an SGLT2 inhibitor. And I know you're going to ask the reason for that, so I'm going to allude that already. SGLT2 inhibitors were not indicated for heart failure nor approved when we started the trial. So we did not want to have a disbalance in two groups. Now, of course, the comment is, can we extrapolate the primary results, which we will talk about in a minute, I assume, to the group now? Because now everybody is on an SGLT2. And I already think yes. The answer will be yes. Why? They work synergistically. SGLT2s have been proven to increase a little bit of diuresis, but they don't increase natriuresis. They only interfere with 5% of the sodium uptake in the kidney. Well, acetazolamide interferes with 60% of the sodium uptake in the kidney. So they work completely different.
Okay. And you've already alluded to the primary treatment effect, so tell us what that is.
Yeah, we kept the best for last, right? So the primary endpoint was, is your patient dry, based on absence of edema, pleural effusion, ascites, after 3 consecutive days of diuretic therapy. And we hit the primary endpoint overwhelmingly. We had a 46% improvement in decongestion. So 46% more people were decongested after 3 days of consecutive diuretic therapy. This was with a p-value of 0.0009, tremendously effective. Number needed to treat was around 8 only after 3 days. What's more was that the therapy led to a reduction in hospitalization. That was a secondary endpoint. So we saved 1 day of hospitalization, which will reduce healthcare-related costs and also will probably improve quality of life sooner. And then you can wonder, does the therapy really help, or can I make it up if I don't do it initially? So we also collected data at discharge. And it was clear that the benefit of acetazolamide was maintained at discharge. There too, there was a statistically significant increase in the number of patients decongested at the moment of discharge. The reason for that is there are 2 reasons. First of all, acetazolamide increases natriuresis a lot more than diuresis. And secondly, we noted an incremental benefit of the drug over consecutive days. So that means you cannot make it up. We have to treat congestion early on and very aggressively with a combination of diuretic agents.
Now, because your comparator group had placebo versus an equivalent added dose of a loop diuretic, how do you know that the treatment effect is due to acetazolamide rather than just higher dose equivalence of a diuretic agent?
Well, that's hypothesis generating, you know, Mariette. And of course, that might be true. And you might now ask the question, what would have happened if we would have given a thiazide, for example?
Yeah, that could have been another...
Why don't you do the trial?
I would potentially agree to doing a trial, except that my focus is health services implementation, although this would be a really great question to answer.
I couldn't agree more. But, you know, we have to stick to science and to data that we have. So we set up the trial like this. And I think this is the first trial now
so exciting.
In acute heart failure that shows that you can decongest better in a safe manner. We didn't touch upon that. It's easy to use and it's off patent. So the drug is almost for free. So I don't see any, of course, you have to be critical about the data. But I don't see any reason why we cannot deploy or employ this strategy tomorrow.
And how do you continue on therapy beyond the hospital stay? Any ideas?
Yeah, so our thinking in the heart failure world has always been, my thinking has always been, you have to, the initial phase is all around decongestion. You have to get rid of the fluid out of your body. And then, of course, you install the goodies, the disease-modifying agents. The disease-modifying agents will kick in a lot better in an environment where the congestion part is relieved. Those medications, the disease-modifying agents, aside a little bit for the SGLT2s, will not decrease the congestion acutely. The patient comes in suffocating with a lot of edema. That is the target for diuretic therapy. And acetazolamide now has unequivocally proven to do a better job in combination with loop diuretics than loop diuretics monotherapy.
Right. So no plans, or not the continuation of acetazolamide was not sort of part of the protocol or planned investigation.
No, it's not part of the protocol, so I cannot say it's safe to give it on an oral basis long term. We don't have the data to say so.
Yes.
It may be helpful, but again, I think diuretic therapy should be temporarily during the decompensation phase, and then we have to lower down, hopefully stop them, to increase the dosage of the neuromonal blockers.
Absolutely. 2 important points. Thank you so much for your discussion with us. Congratulations on a beautifully run trial and its impact on clinical care, providing us with more in the armamentarium to decongest patients and help them feel better following decompensated heart failure. Thank you, Professor Mullins.
Thank you for having me.
The exciting bit for me is really the interplay of the various disciplines. So my research group is now working mainly on metabolic aspects, from cardiology to oncology to nephrology, and bringing all these disciplines together. So I think that's the really exciting thing 2022, that we're not separating anymore that much between disciplines. We're growing together, and I think that's for the benefit of the patients. In terms of advice for the younger researcher, I think it's important to have a vision. It's important to work hard on your research dreams and to find a supervisor where just the collaboration works perfectly, because it needs some guiding in the first years. So I think the important bits are you need to burn for the research and you need to be in the right team. My name is Harald Zori. I'm from the Medical University in Graz, and I'm heading there the interdisciplinary metabolic medicine trials unit. The EMI trial was started after we have seen the first results of the SGLT2 inhibitors, and we now know that there are beneficial effects of the SGLT2 inhibitors in heart failure across the entire range of left ventricular ejection fraction. And we see also a very early effect after the initiation of the treatment. So keeping that in mind, and the fact that myocardial infarction is a frequent reason for heart failure, we thought it might be beneficial to start early after an acute myocardial infarction with an SGLT2 inhibitor treatment and see where this is leading, whether this can have some beneficial impact on cardiac function, on cardiac structure, and biomarkers of cardiac function. We performed a randomized, controlled, placebo-controlled, blinded trial, and we enrolled 476 participants, and they were basically equally allocated to one of the treatment groups. And we included them right after the acute myocardial infarction, so within 72 hours. And we brought them back in for another visit 6 weeks later, 12 weeks later, 26 weeks later. And the primary outcome of the study was the change in NT-proBNP at week 26 between the two groups, and of course cardiac function and structural imaging on echo. Well, what we have seen is that the NT-proBNP levels were 15% lower with empagliflozin as compared to placebo, which was statistically significant. We have also seen an improvement in left ventricular ejection fraction and diastolic function parameters, and we have also observed a reduction in left ventricular end systolic and end diastolic volumes, giving us kind of a robust picture of beneficial effects with empagliflozin in this cohort. we had the data in heart failure. There is now more and more data emerging in kidney function. We had diabetes data, but so far we didn't have a lot of data with empagliflozin in myocardial infarction. So this is a first important step. But of course, it's not an outcome trial yet. Although the data look intriguing, we of course need to wait for the DAPA-MI and for the EMPACT trial to give us the definitive answer.
I think that the most exciting part of cardiovascular research at the moment is the application of big data, and I'm a very big fan of acquiring big data resources to truly let us understand the statistical distribution of outcomes and parameters that we measure as they relate to mortality. And this is game-changing because we've had small data sets extrapolated to large populations, and what we need is large data sets that we can extrapolate to the general population. Leadership is a deprivation of self. It's an understanding that we need a multidisciplinary, multi-speciality collection of individuals to synergize together to create things more as a group than we can on our own. And leadership really feeds into bringing those groups of people together and allowing people to flourish. And I think that's incredibly important to empower people to feel safe in their environments, to work together, to make mistakes, but to collaborate collectively to the betterment of the outcome for the patients that we serve. My name is Professor Jeff Strange from the University of Sydney, Australia. I'm the Chief Investigator of the largest echo study in the world, the National Echo Database of Australia. So we have been working on producing an artificial intelligence decision support software for the detection of aortic stenosis. Aortic stenosis is underdiagnosed globally. At best, we're transferring less than 70% of patients onto receiving their aortic valve repair, or replacement, sorry, and we need to work better with our echocardiographic colleagues to identify the right patients at the right time to go to the heart valve team. Yes, so we've developed an artificial intelligence decision support software that uses a modified mixture density network, neural network, which is a fed-forward network that takes the Gaussian distribution of outputs of all the echo variables, all of the structural changes in the heart, and it uses all of that information to predict those patients that will have a poor outcome with aortic stenosis. So the study design is a clinical cohort study of real-world echocardiographic data fed into a neural network that derives the multi-dimensional relationships between ventricular response, atrial response, and the pulmonary circulatory response to a stenotic or stiff valve. And the way that the artificial intelligence works is it takes that multi-dimensional relationships and gives a probability output that the patients will have a risk stratification, either severe, moderate or low risk, for a mortality event within 1 to 5 years. Yeah, so we're excited to present our artificial intelligence decision support software at the hotline session at ESC on Sunday the 28th. We're presenting data on 1 million echocardiograms on more than 630,000 individuals, where we've trained an artificial intelligence algorithm to risk stratify patients with severe, moderate or low risk aortic stenosis phenotype. Aortic stenosis, as I said, is very underdiagnosed. We estimate that less than 10% of patients are making their way through to the heart valve team for a decision on what valve strategy to put into patients. So what we need to do is reframe the way that we're communicating the results from echocardiography, and in doing so add an artificial intelligence algorithm to identify the right patients to go through to the heart care team at the right time. I think the time has come for a change in echo reporting. We need a call to action for our cardiology colleagues to know when to act, who to act on. We've currently got a dichotomy of guidelines that leaves people either not treated or sent for treatment, and it's a spectrum of disease, and the use of this multi-dimensional artificial intelligence module actually allows clinicians to understand the sequelae of what's happening in the ventricle, its response, the atrial response, and the pulmonary circulatory response to that stiff valve. And having this algorithmic decision support software is going to aid in that call to action for those people interpreting echo reports.
Well, I think cardiovascular research in general I've always found fascinating. I enjoy it tremendously, and I think I get to do every day what I want to do, in the sense of I'm researching or exploring diseases, problems that currently don't have an answer, and I can pick which ones I want to do. I can explore it in detail. So actually you get paid for doing the things you enjoy, which makes, for me, makes it a real pleasurable career and doing it. And in 2002, we now know so much more, but every time you find out what new things, then that spawns yet more ideas and more things to do. So 2022 is a fascinating time to do cardiovascular research. So I think for you, junior trainees, they're often focused on getting their clinical training under the belt, and rightly so. But I also think that they should embrace training in research, because it is a fundamentally important part. It will determine their future practice, whether they engage with it or not. But why not be part of it? Why not help make those changes in future practice, and how exciting that is. Hi, I'm David Newby. I'm the British Heart Foundation Duke of Edinburgh Chair of Cardiology at the University of Edinburgh. So the PREFER study set out to really demonstrate that we could actually identify hot, inflamed atherosclerotic plaques without inserting any catheters into the body. We can do this with an imaging technique that can be done in routine clinical practice. So the study design was an international, prospective, longitudinal cohort study. It was performed in 3 continents, 4 countries, 9 centres. What we did was we recruited patients who'd had a heart attack, acute myocardial infarction, but also had multi-vessel disease. And what we did is we performed a sodium fluoride PET CT scan, and then we followed them up for an average 4 years, a minimum of 2 years. And we looked to see what the rates of death, heart attacks, revascularization were in these patients. And what we found is that in the 704 patients who were recruited, that this imaging technique could identify the risk of patients going on to have recurrent myocardial infarction and cardiac death. And indeed, it also predicted all-cause mortality. So this is, we'd done previous studies demonstrating that sodium fluoride PET CT could identify the culprit plaque in patients who'd had a myocardial infarction. What we wanted to do is to prospectively evaluate it. So with previous data in around 300 patients in retrospective study, that demonstrate there was an association with fatal and non-fatal heart attack. So the reason we did this study was to prospectively validate that finding and show in a real-world population with multiple different scanners in different hospitals across the world that we can still use this technique and it continues to predict the risk of heart attacks. So to date, when people have been looking at high-risk plaque, they've used invasive techniques, intravascular techniques like intravascular ultrasound and near-infrared spectroscopy. And there has been some associations, particularly with revascularization events with those techniques. But those techniques, you have to insert a catheter down each of the 3 coronary arteries. You have to do that during cardiac catheterization. So it's not very practical, and it's certainly you can't do it in everyone and easily. So this technique you can do in anyone. It doesn't require you to instrument the coronary arteries. It's an external scan, and as I say, PET scanning is routinely available. We use it a lot every day in clinical practice for patients with cancer and oncology practice. Well, actually the trial wasn't, if I'm honest, particularly challenging because I think what we demonstrated is that in centres that hadn't done cardiovascular PET imaging before, we could actually readily do this. And the tracer we use, sodium fluoride, is the simplest PET tracer we have. It's even simpler than FDG, which is used in oncology practice. So in a sense, it was challenging to get the notion across. But once we initiated that, we found that centres were actually very easily and readily able to actually do the imaging themselves.
Well, I am myself an early career research fellow, and I think the key thing that I would advise is if you can find opportunities in your local trials units or even within your universities, if there are larger trials units where you can get some experience with randomized trials, that's probably the best place to start. Because rather than attempting to conduct smaller trials on your own to learn about trials, working with a large trials team will help you to understand how trials are conducted and designed and understand the methodology better. And I think that is your stepping stone towards getting into the big trials scene, which is where all the action is. I think over the last few years we've seen a lot of interesting new therapies being developed and rolled out, and we've seen very well conducted large-scale randomized trials providing us with excellent information. Looking at the series of studies that were published on the SGLT2 inhibitors and more recently the PCSK9 program for LDL lowering. So these are all areas in cardiovascular research that have really filled me with hope that we are going to keep discovering and going to keep conducting trials in a way that we can bring lots of good treatments that are beneficial to patients worldwide. And I think that's quite exciting as a cardiovascular researcher. So my name is Michelle Gunasekara, and I am a clinical research fellow attached to the Nuffield Department of Population Health at the University of Oxford. I am a nephrology registrar by training, but I am currently working on cardiovascular trials, and that's me. So many people will be familiar with the original ASCEND study, which looked into the effects of randomization to aspirin versus placebo and separately to omega-3 fatty acids versus placebo on atherosclerotic cardiovascular disease. So our study is a secondary analysis of that original study, looking into what the effects of these two medications are on heart failure. Because heart failure is a condition that affects individuals with diabetes in particular, and there are over 400 million people worldwide with diabetes, and there are doubts and uncertainties in the current research areas about what the true effects of aspirin and omega-3 fatty acids are on heart failure. So we are hoping that this study will add further information to that mix. The ASCEND study was a double-blind, placebo-controlled randomized trial which had a 2x2 factorial design, and we randomized people to aspirin versus placebo and separately to omega-3 fatty acids versus placebo, and that was a total of over 15,000 participants. We conducted our follow-up using mail-based follow-up methods using questionnaires every 6 months. And importantly, we also had access to routinely collected data, which we used in outcome ascertainment, which I think is an important methodological piece of work that we did as well. And in terms of selecting the omega-3 fatty acid dose, at the time that ASCEND started, 1 gram was the dose that was in use and we had evidence for, because I think studies like JELIS and GISI Prevention suggested that there could be a benefit of the 1 gram dose of omega-3 fatty acid, and which is the rationale for using it. And unlike the newer studies which are looking at the effects of triglyceride lowering, which was not a goal in ASCEND. So the primary outcome of our analysis is the effects of randomization to aspirin and separately of randomization to omega-3 fatty acids versus placebo on hospitalizations or death due to heart failure, with our key secondary outcomes being the individual components of the primary outcome. And for the aspirin result, we've shown that randomization to aspirin does not have a significant effect on the primary outcome of death due to heart failure or hospitalizations for heart failure. The rate ratio was 0.98, and our confidence intervals extended down towards a proportional benefit of 17% and up towards a proportional hazard of 17%. And there were no significant effects on the secondary outcomes of hospitalization for heart failure or death due to heart failure. For omega-3 fatty acids, there was again no significant effect of omega-3 fatty acids. The rate ratio for the primary outcome was 0.88, with confidence intervals here extending down towards a proportional 26% reduction and up towards a proportional 5% hazard. So in summary, there was no significant benefit, but for omega-3, we've ruled out any hazard, but there is a possibility of benefit as much as 26%, whereas for aspirin, we can't fully rule out small to moderate harm or benefit. I think now that there is a lot of different studies looking into this question of what the effects are on heart failure, the next step would probably be to undertake a more broad meta-analysis of all the data to try and see what the trend is based on all the different studies and whether it's confirmed in a final pooled result. And for aspirin, we don't really have enough data because we've got this study result that's come out, and then ASPRI, which is a trial of older adults looking into primary prevention, has published their results showing no significant effect. So those are the only 2 studies that are out there, and hopefully perhaps the ARRIVE trial also does some analysis on heart failure outcomes. We may have enough data to look into the question and answer it more definitively so that we can move on to other areas. I think with aspirin currently the problem is that we don't have enough benefit in the primary prevention setting that can counterbalance the increased risk of bleeding. So I think the key message here is that randomization to aspirin versus placebo did not have any significant effect on hospitalizations or death due to heart failure. But we couldn't rule out the possibility of a small to moderate benefit or harm. And for omega-3 fatty acids, again, we did not find a significant effect of randomization to omega-3. However, we've ruled out the likelihood of harm, but there is still the possibility of modest benefit that we haven't been able to exclude. Thank you.
Hello everyone, welcome to this Radcliffe session from the ESC, and I'm live here at the ESC with our two chairs of the new cardio-oncology guidelines. It's been a momentous last few days in cardio-oncology, the first international comprehensive guidelines in cardio-oncology, and who better to take us through them than Dr. Alex Lyon from London and Dr. Teresa Lopez Fernandez from Madrid. Thank you so much for being here and taking us through the guidelines.
Thank you, and thank you for inviting us to present the new ESC guidelines on cardio-oncology. As you know, these are the first ESC guidelines on cardio-oncology, and for sure, I'm sure that you are aware that this is a multidisciplinary teamwork, and we always, when we present the guidelines, we want first to thank all the task force members for the incredible work they did, as well as the reviewers and the ESC team that support us during the last 2 years. So this is the general overview of our guidelines. We include 272 new recommendations that are formed regarding the most permissible but also the most efficient cancer treatment. And we cover all these different topics in the guidelines. So guidelines provide new definitions and also strategies for personalize the prevention and the monitoring of different cancer therapies, as well as how to manage the potential problems that this patient could develop during and after the cancer treatment. And we also focus on how to organize the long-term surveillance of this patient and also on special population. So these figures summarize two of the key messages of the guideline. The first one is that the risk of suffering cancer therapy-related cardiovascular toxicities is a dynamic variable that changes through the pathway of care. And that's why we need to organize personalized monitoring during and after treatment. But the first step is to really focus on how to adjudicate events in cardio-oncology, and that's why we introduced as a first chapter in our guidelines the new international definition of cancer therapy-related cardiovascular toxicities that include also this new descriptive term of cancer therapy-related cardiac dysfunction. We try to describe with CTR-CD the broad spectrum of heart failure symptoms that may occur in some patients. So symptomatic CTR-CD means symptomatic heart failure, and we have different degrees of severity, and according to this severity we make appropriate treatment decisions. And we also have different degrees of asymptomatic CTR-CD, that means asymptomatic left ventricular dysfunction, based on different cutoff of ejection fraction and ELS, and also on the increase in cardiac troponin. The first step when a patient has a new diagnosis of cancer is to try to stratify his or her baseline cardiovascular toxicity risk. And we need to use tools that manage all these cardiovascular risk factors and also previous cancer history and previous cancer treatment. And in the guidelines, we support the use of this Heart Failure Association and International Cardio-Oncology Risk Tool. These tools have been published a few years ago by these two societies and try to summarize for different drug classes what are the risk factors that are more important or we need to consider. And when we feel these different performances that are now available at the ESC APP, you can establish a different level of risk of your patient according to the treatment he or she is going to receive. So after this baseline assessment, that of course include a clinical assessment, also an ECG for all the patients who are going to receive cardiotoxic cancer therapies, and other tests like echo or biomarkers according to the level of risk. So once you finish your baseline risk assessment, every patient fits in one of these three categories: low risk, medium, moderate, medium risk, or the high and very high risk. And that's the only way the oncology team can make appropriate treatment decisions. We can also educate patients to promote healthy lifestyle, and we need to educate patients on their own cardiovascular toxicity risk because we need them involved during the treatment. And of course, we recommend different degrees of referral for patients. So we manage different protocols for monitoring of the treatment, and this is an example. This is anthracycline chemotherapy surveillance protocol, and as you can see on the left, the different risk categories, and according to these risk categories, we establish precise recommendation on ECG, troponin, echo, or in other classes of drug, other type of complementary tests. And now I'm going to hand over to Dr. Lyon, who is going to talk about the management.
Thank you, Teresa. So I think it's important to emphasize that this is a guideline for the cardiovascular diseases in cancer patients. And so in the management of cardiovascular disease, we focus on where treatment decisions are different to patients without cancer, which are of course covered in other ESC guidelines. And the different factors you should consider for a patient with cancer, of course, is their cancer-related symptom burden and their cardiovascular symptoms, what their cancer stage and prognosis is, the treatments that they've been receiving, and potential future treatments, including non-cardiotoxic alternatives, the cancer drug, cardiac drug interactions, and we have an extensive list of those in the data supplement, and of course patient preferences. And we cover a whole range of the different cancer therapy related cardiovascular toxicities as summarized in this slide. Just to give one example, which is the management of trastuzumab targeted therapy and its related dysfunction, and this is relevant to all the HER2 targeted therapies. So once a patient has had the problem diagnosed, you'll see in the upper third of the algorithm, are they symptomatic or asymptomatic, and what is their severity as per the definitions that Teresa has just shown you. In the middle third of the algorithm are the decisions on oncology therapy. So severe cases, trastuzumab is interrupted, whereas we'd like to highlight in asymptomatic moderate CTRCD, where the ejection fraction has fallen to below 50%, but in the range 40 to 49, if the patient's asymptomatic, it's a class 2A indication to continue trastuzumab with close cardiac monitoring. And then in the lower third of the algorithm is the cardiovascular management plan. So patients with moderate or severe CTRCD, whether it's symptomatic or asymptomatic, should have heart failure therapy. That's a class 1 indication. And for mild asymptomatic CTRCD, which we see more and more with surveillance, if the GLS has fallen or biomarkers have risen, it's a 2A indication to start an ACE inhibitor or a beta blocker. And here are examples of the algorithms for anthracyclines, for Takotsubo syndrome, checkpoint inhibitor-related myocarditis. We also cover the very difficult topic of the choices of therapeutic anticoagulation for atrial fibrillation and venous thromboembolism, different cutoffs for arterial hypertension when it's caused by a cancer drug, and also QT monitoring and how to manage the patient on a cancer treatment who develops QT prolongation. A really important new area is a focus on an end of cancer therapy cardiovascular risk assessment. We've heard about it at the beginning. We now have introduced the concept of doing it in the first 12 months when the patient has completed treatment, because this will enable you to guide what their long-term strategy is. And here is a table of the risk factors for identifying people at high risk for future development. Now, another important topic is long-term surveillance, and we know that some patients develop their cardiovascular problems years after initial treatment. And again, we can divide the groups into low, medium and high risk, and this will guide us on the frequency of
surveillance, for example, with transthoracic echocardiography. And on the right, you'll see we have risk factor groups, both for the adult survivors of childhood and adolescent cancers, and below the risk factors for adult cancer survivors and who is high risk and needs this closer monitoring. And in the final clinical section, we also focus on some special populations seen in cardio-oncology services. That's patients with primary cardiac tumours, the valvular complications of carcinoid syndrome, cardiac AL amyloidosis in patients with multiple myeloma, and the group of pregnant women who develop a cancer during pregnancy that needs anthracycline chemotherapy. We also have these algorithms for identifying and how to manage patients who've got a cardiac implantable electronic device, such as a pacemaker or a defibrillator, where they need radiotherapy that could interfere with the device. So again, we just want to thank all the co-authors who've helped to build this guideline and work tirelessly over the last 2 years, and we really hope it helps you in the management of these complex patients.
Great, thanks so much Alex and Teresa for that fantastic overview of the guidelines. So, generated a lot of interest. There's been a lot of buzz here at the conference and also kind of online, so we've got a number of questions coming through. So first of all, we have a question from Irma Bisglia. One of the questions I have relates to the placement of biomarkers in class 1 in high-risk patients undergoing anthracycline treatment and the serial blood test required in each cycle as 1B. This can create a number of extra blood tests for patients. Do you have any comments regarding this? So maybe, Teresa, if I could start with you for this one.
Yeah, well, not sure that this leads to extra blood tests, because before each cycle of anthracycline, the oncologist did a blood test. So we just need to click the button of troponin or NT-proBNP. And we think, and reviewing all the literature, that biomarkers are quite cheap and quite easy to help the monitoring. Is it true that they are sometimes too sensitive, and we need to interpret the values in the clinical context of the patient? That's why it's very, very important to have baseline values, because if not, we cannot identify what really means increase in cardiac biomarkers. That's especially for anthracyclines, and especially for patients who are going to start trastuzumab therapy and receive previously anthracyclines. There are a huge number of articles that refer that these biomarkers can detect mild asymptomatic CTRCD, and probably is to treat this mild asymptomatic CTRCD is the right way to prevent a serious event.
So I think it's an important message that although it's a class 1, don't bring people in for an additional blood test.
Yeah.
Take the opportunity when they're coming to the chemotherapy unit and getting their baseline bloods. And you don't delay the chemotherapy that day, it's how you interpret it for the following cycles.
And would you recommend that it's the oncologists who lead on this process, and tell the cardiologist if there's a rise or a problem?
Yes, I think for a lot of these guidance, particularly the baseline risk assessment and surveillance, all the patients are in the oncology clinic or hematology service. So we need to work with our hematology and oncology colleagues to educate them about the guidelines so they can implement the advice and the recommendations, but know what to do if a troponin value rises or if the GLS reduces. So they've got to be educated about GLS, a new concept often for them.
That's an interesting question. So we have a question on GLS, so leads nicely onto that. So is it possible to have an abnormal LV strain in oncology patients who have no other cardiovascular risk factors, and what would you do in that context?
So that's a great question. I'm getting to think about one of two patients. The first is the treatment-naive patient. So if you've got someone who is got no previous cardiovascular history, they're treatment-naive and their GLS is reduced at baseline, it still raises the question why in the context of a normal ejection fraction. And we know some cancers release chemicals that are potentially cardiotoxic, particularly some of the very metabolically active cancers. acute leukemias, some of the very rapidly progressing lymphomas. So we do see cardiac dysfunction at baseline, and that patient is a higher risk. Then we also see the GLS falling during treatment, and maybe that's a different population where they've now had a delta change, and then the guideline gives advice about what to do with those patients.
Specific question on checkpoint inhibitors. Do you recommend any screening prior to starting checkpoint inhibitors for medium to high risk patients? Maybe, Teresa, if I could start with you for this one.
Well, in fact, we divide the population who is going to receive immunocheckpoint inhibitors in two groups, low and moderate risk and high risk. And is it true that when we compare with other cancer drugs, the definition of the high risk group is not so precise as in other scenarios? But for sure, patients at high risk are those with previous cardiovascular diseases who are going to receive more than 2 drugs or 2 immunotherapy combination, who are going to receive at the same time chemotherapy, radiotherapy. So to have a baseline risk assessment of this patient is critical, particularly with biomarkers, because some of these patients have a high level or median increase in NT-proBNP or cardiac troponin because of previous history of ischemic heart disease, or just because they have a high cardiovascular risk. And if not, it's very, very difficult to interpret the results during the treatment.
So the guideline says everybody who's going to receive a checkpoint inhibitor should have an ECG and the troponin measured at baseline, and the high-risk patients get the echocardiogram. I think it's just so we know what's going on, and often these patients can have symptoms and they haven't really had the management. They've got a new progressive malignancy, so there's also the opportunity to help.
So I think one of the key things my take home from the guidelines is that a lot of baseline assessment for all cancer patients to just understand where we are before something happens. So how best to kind of manage this? Should we be doing it as cardiologists, or is the burden then on the oncologist? I mean, practically, how can we implement this?
So I think it depends what the components of the baseline assessment are. So we've got the HFA ICOS risk assessment. It's now actually in the app. So if the oncology colleagues and hematology colleagues download the ESC guideline app, they can have the interactive tool and in their clinic be able to calculate it. I think they can do ECGs, they can do the blood tests. We have to have a relationship so they can order echo rapidly. The first echo for a patient is a comprehensive echo because we don't know what we're going to find, and thereafter can be focused. So as a cardiology service, we've got to work with them to be able to deliver what they need, but some of this is their responsibility because we can't see every patient on these treatments. We need to see the right patients, which is where the guideline says it's a class 1 indication to refer the high-risk patient pre-oncology treatment. Of course, in the context that time allows, it's not an oncology emergency where they must start treatment.
There's an interesting question, maybe slightly outside of the guidelines but related. Should we be doing specialized cardiovascular safety RCTs with oncology drugs similar to those done with anti-diabetic medications? So a bit of a kind of, not a loaded question, but maybe relevant for future guidelines.
Well, I think my approach is if you don't know the cancer drug works, then it's not worth spending a lot of resources to do a safety study. So if the cancer drug works, then we need to think about how we manage that. In classes of drugs where we know there is a cardiotoxic signal and another trial's being done, the checkpoint inhibitors or a VEGF TKI and another treatment, it seems logical to do a cardiovascular safety sub-study and maybe something on everybody, troponin or ECG, and then a sub-study looking at advanced imaging that could then pick up where we have a true concern. But if it's a first-in-class drug, and these are coming down the pipeline a lot, I think we need to know they work on the cancer first.
So, Teresa, there's been a lot of talk about the late effects part of the guidelines, and I think a lot of people welcome this very much. Some of the questions that I've been hearing from general cardiologists is how can we fund such a service, and should it be cardiologists or should it be oncologists? So what are your thoughts on that?
Yeah, this is a really difficult piece to organize because we have a huge number of patients to manage, and of course, again, as during the treatment, in the cardiology services, we cannot be the only ones who take care of these patients. So again, risk stratification at the end of cancer therapy gives us the clue which patient really needs a specific cardio-oncology follow-up that with the help of the oncologists, the hematologists, and also GPs, I think is the right way to organize the cardiovascular surveillance of cancer survivors, because we need to perform a yearly cardiovascular risk assessment, a standard cardiovascular risk assessment. And just in a few patients who are treated with a specific drug, we need other specific complementary tests. But what we need is to promote healthy lifestyle in these cancer survivors, because statistics give us high numbers of uncontrolled cardiovascular risk factor in this population. And the first doctor that sees a patient with poor control cardiovascular risk factor needs to go to deal with.
And maybe it's that first year, the end of year assessment, they're still under the oncology clinic. So there we're liaising with the oncologist, but then there'll be that natural transition from oncology care, hopefully if they're cured, to the primary care, and the cardiology team has to then coordinate with both.
Okay. So there's a question now on 5FU. Asking any role for algorithms about heart failure and direct toxicity due to 5FU rather than ACS or ischemia.
So we do see this. I think we have not included an algorithm specifically because really there's no data out there as to A, how common is it? B, what should we do? It's very difficult, but we do see it in our day-to-day practice. But compared to the more vascular toxicities of the fluoropyrimidines, which are more common, so I think that is clearly in the area of the gaps in evidence. You know, we need future studies to provide the data so a future guideline can then directly address that. But we have not covered that topic really because there was very little in the literature and we didn't feel that that was a topic that we could include. But we recognise that patients do exist with it.
Great. So I think that that's most of the questions that have come through, and I'm aware that we're kind of coming towards the end of our time. So thank you very much for the presentation. Thank you for answering all the questions that came through. And maybe if I hand over to you, Teresa, to give your last take-home messages.
Wow. So maybe the key messages is that we need to stratify cardiovascular toxicity risk, and we need to work really close to the oncologists and the hematologists for this task, but patients are in oncology and hematology clinic, so we need to educate them, as Alex told you before, to try to organize good referral pathways to the cardio-oncology area. And another really key point that sometimes is forgotten is the re-stratification of the risk at the end of cancer therapy. So, because if not, it's really impossible to organize a comprehensive cardiovascular surveillance for these patients.
Okay. Thank you so much once again to Alex and Teresa for your very great work over the last so many years to get this to fruition, and hope the audience and most importantly our patients will benefit from the new guidelines. Thanks for joining us.
I think cardiovascular science is evolving tremendously, and with new drugs and new devices and with a lot of innovation. And as we are saying now, the cardiologist of this decade is going to be the metabolic cardiologist, where we're going to have to understand a lot about diabetes and lipids, but really coming with agents that can change the risk and not change just a biomarker such as LDL or glucose or hemoglobin A1C, but really drugs that can change cardiovascular risk. So I think we need to be all thinking about cardiovascular risk. And also don't forget about the importance of prevention. I think preventive cardiology is also the key aspect of the next 2 decades in cardiology, how to prevent patients to really get sick and think about lifestyle, food, exercise, and things like that. To be a successful cardiologist and researcher, I think first, people need to do the right things for the right reasons, with the right motivations. That's critical, and give 200% of yourselves, because there is no free lunch in life, as I used to say. So we really need to work hard in terms of really do things for the right reason. There is no shortcut. I think the second piece of advice would be passionate about what you do, because if you really do what you love, you're not going to have to work a single day of your life. So just do what you love. And third, for the younger generation, make sure you find the right mentor. I think mentorship is one of the most important aspects for the success of any career, particularly in cardiovascular medicine. So make sure you have the right mentor next to you, helping you achieve what you want. Hi, I'm Renato Lopez, cardiologist from Duke University in Durham, North Carolina. I think in the last 2 years, we've made tremendous progress in the COVID field, because at the beginning of the pandemic, everybody was treating patients based on no high quality evidence, on several potential and mechanistic studies and observational studies, trying to do something for patients. And we know that this can be very dangerous, because we don't know if something really works or not. But I think the scientific community was able to really bring along amazing and well-designed studies in different fields, and really create a lot of high-quality evidence very rapidly, that in 2 years now, we have a much better sense of what works and what does not work for patients with COVID-19. So in this sense of bringing up high-quality evidence, the Apollo trial, I think, is another piece for this puzzle of the role of anticoagulation for patients with COVID-19. Of course, we learned that patients are at different risks for thrombotic events. If they are out of hospital, if they are in the hospital, if they are in the hospital but in the ICUs, or even when they go home. There are different risks of these patients having thrombotic events, and different studies look at different strategies on how to minimize these risks of thrombotic events. Particularly in the outpatient setting, we didn't have a lot of high-quality data. We have some randomized trials, and what the Apollo trial did is really try to test low-dose apixaban, 2.5 milligrams twice daily, versus placebo in a double-blind, placebo-controlled trial in patients who have COVID but are not sick enough to go to the hospital, so they are at home being treated with symptomatic drugs, and but at increased risk for thrombosis, so with elevated D-dimer or other classic risk factors for thrombotic events. So that's what the Apollo trial wanted to answer. And what we showed is that when you treat these patients with low-dose apixaban, it did not improve in general outcomes, and it did not have an impact in the number of days alive and out of hospital at the end of 30 days. So basically giving high-quality evidence that we don't need to routinely anticoagulate patients in the outpatient setting when they have COVID-19. Yeah, so I think Apollo is another piece to the puzzle. There have been already some studies demonstrating that there is no benefit of using anticoagulants, different types of anticoagulants for patients with COVID out of the hospital, patients with COVID that don't need to be hospitalized. And I think Apollo brings and confirms this data now with a different agent, apixaban, in a different dose, 2.5 milligrams twice daily, which is a lower dose than the classic full dose apixaban. But again, with the results aligning with the other pieces of data that we have so far in the outpatient setting. Well, I think COVID continues to change, different variants and different aspects, and I think we're going to continue to learn about COVID and having to be very smart and fast in designing trials to try to answer the questions that we need in each given time of the infection.
Yeah, so I first became interested in cardiovascular science when I was a senior medical student. And at that time, I had the opportunity to work with cardiologists who had either led or participated in clinical trials. And I really was enamored by the thoughtfulness of their approach and impressed by the importance of understanding or developing evidence to contribute to the clinical decisions we make. And I'd say that even though I'm further along in my career at this point, that still is a message that has stuck with me, is that there's something incredibly important and powerful about trying to contribute to the evidence base that supports our clinical decision makings. And so I think there's a lot of new questions, even since I was a senior medical student, that have defined cardiovascular science today. And I think that there continue to be important clinical questions to be answered. So we need more effective therapies for a range of cardiovascular diseases. And it's wonderful to be a part of it. I think it's a wonderful field to be in. Cardiology cardiovascular medicine there's so much that is covered by cardiovascular medicine, and it's so important, and your ability to make an impact is huge. What I would say is it's important to be passionate, it's important to be motivated, it's important to want to address important questions and to think about questions that you think are important to ask. I think it's also important to be flexible. The questions that we ask today in cardiovascular medicine are different than the questions we asked a decade ago. And so as opportunities come up, it may not have been the question you thought that you initially set out to answer when you were at the very beginning of your career, but nonetheless, it's an important question, and being open to those opportunities and welcoming new opportunities, I think, is an important thing to be successful. My name's David Berg. I am a cardiologist at the Brigham and Women's Hospital in Boston, Massachusetts, and Harvard Medical School, and an investigator in the TIMI study group. So very early on in the pandemic, it was appreciated that patients with COVID-19 have an increased risk of developing blood clots. And that risk is particularly elevated in patients who are admitted to an intensive care unit, who are critically ill. And so that led to a number of studies testing antithrombotic therapies in patients with COVID-19. And the designs of those studies, the specific population studied, the specific interventions, and the clinical endpoints have been somewhat different for each of those studies. The largest of them, and the one that's really informed clinical practice to date, is the so-called multi-platform study. That study had a separate study for non-critically ill and critically ill patients. And both of those studies compared full-dose anticoagulation compared with usual care. And the primary endpoint was focused on organ failure, so it was days alive free of organ support. The surprise finding in those studies was that there was directionally opposite results. So in non-critically ill patients admitted to the hospital but not in an ICU, there appeared to be a compelling benefit of full-dose anticoagulation. That was not seen in critically ill patients. And so the fact that these results were disparate has led to some confusion on the part of clinicians about how to integrate those results, particularly because we see the highest levels of thrombotic events in patients who are critically ill. So COVID-PACT was a study that focused on critically ill patients with COVID-19. They were random. It was a 2x2 factorial randomized controlled trial. Patients were randomized to either full-dose anticoagulation or standard-dose prophylactic anticoagulation as a strategy. And then if a patient was not already on an antiplatelet therapy, they underwent a second factorial randomization to either clopidogrel or to no antiplatelet therapy. And they were followed through the end of their hospital stay or to 28 days after randomization. The primary endpoint in that study was a composite of venous and arterial blood clots, which was different from the multi-platform study. What we showed in the COVID-PACT trial was that for the anticoagulation randomization, that treatment with full dose anticoagulation, as compared with standard dose prophylactic anticoagulation, reduces the risk of thrombotic complications by 44%. By contrast, for the antiplatelet randomization, there was no difference in the risk of blood clot formation in patients who were on clopidogrel as compared to no antiplatelet therapy. And so what I think we learned from this study is that there was a compelling reduction in clotting events. We also, of course, looked at bleeding events. And what we found is that patients on full dose anticoagulation as compared with standard dose prophylaxis did not have a significantly increased risk of fatal or life-threatening bleeding, but there was an increased risk of non-life-threatening bleeding. So this study focused on critically ill patients with COVID-19, who are the patients who are at highest risk of developing blood clots. And what we showed in the COVID-PACT trial was that a treatment strategy focused on full dose anticoagulation as compared with standard dose prophylactic anticoagulation reduces the risk of life-threatening blood clots with an increase in non-life-threatening bleeding. So considering clotting and bleeding risk, what COVID-PACT tells us is that we should be considering initiating full dose anticoagulation over standard dose prophylactic anticoagulation in appropriately selected critically ill patients with COVID-19. Since they have a very high risk of developing blood clots, we want to reduce their risk of thrombotic complications. As I mentioned before, we saw a compelling reduction in clotting events in patients on full dose anticoagulation. What we also saw was that there was an increase in the risk of non-life-threatening bleeding in this study. And so I think there are still some questions that remain about which are exactly the patients who may be too high a bleeding risk to be able to tolerate full dose anticoagulation. So I think we have some work to do to sort out exactly the appropriate patient selection. But I think as a strategy in the critically ill population, what we can say with certainty now is that full dose anticoagulation reduces the risk of thrombotic complications.
I think we've made, in cardiovascular disease, is one of the areas that we've made the most advances in almost any area of medicine. My father was a cardiologist now 25 years ago, and they had virtually no therapies for acute myocardial infarction. And there's been very little areas in medicine where you've seen a 20% mortality go down to like a 3 or 4%. You know, it is like a 90% reduction in mortality with our existing therapies. And what excites me is that we're developing new structural interventional therapies and other device therapies that have the potential to work with drugs and reduce mortality for patients. Many trainees don't know that they want to do research. And in fact, writing their first paper is a rather painful experience. And I think the analogy I'll give you, it's like taking up a sport or running for the first time. It's going to be difficult at the start. But if you stay with it, you can really enjoy it. And it does require some time and some dedication. But it's a great way to advance your career, see the world, and really make an impact for your patients. My name is Sanjit Jolly. I'm an interventional cardiologist and professor of medicine at McMaster University in Hamilton, Canada. I'm going to take you back to the spring of 2020. And we were a group of cardiology researchers who were hearing stories from Italy and the catastrophe that was happening. Patients were getting crash intubation, ventilation. They're running out of ventilators, and patients were dying of COVID-19. All our cardiology trials had stopped, and we pivoted to do a COVID-19 treatment trial. And we actually did a series of trials. An outpatient trial trying to reduce the load on hospitals, try to prevent hospital admission and death, and an inpatient trial to try to reduce mechanical ventilation, death, high flow oxygen, because we knew that those things were actually very, very important. And we understood from what we knew then that the pathophysiology there were two important mechanisms of COVID-19. One was the inflammation. The inflammation was very, very important. And second, thrombosis. Most patients who were dying were having microvascular thrombosis in many of their organs. So we designed a trial to target those specific mechanisms. So the outpatient trial, we tested two therapies. It was a randomized trial where there were two randomizations, about 4,000 patients, aspirin versus control. to treat thrombosis, and colchicine versus control to treat inflammation. And what we found for the primary outcome for colchicine, which was hospitalization or death, there was absolutely no effect for colchicine compared to control. And for aspirin, when we looked at thrombosis as well as hospitalization or death, there was no significant effect with aspirin. And so it's really clear that, that both these therapies should not be used for the treatment of COVID-19 in outpatients. In the inpatient arm, I think it's important to note that most of these patients were hospitalized but not in the intensive care. 80% were on oxygen. Again, we targeted the same two mechanisms. For inflammation, we used a higher dose of colchicine, a loading dose that had been previously known to reduce IL-6 acutely, as well as maintenance dose for 28 days. And then the second randomization was different. It was a combination of rivaroxaban, 2.5 milligrams twice daily, as well as low-dose aspirin versus control. We randomized 2,500 patients. And what we found was for the primary outcome of need for high-flow oxygen, mechanical ventilation, or death, there was no difference between the colchicine arm and the no colchicine arm. And when you looked at mortality, about a fifth of patients died in the trial. So mortality is still very high, but colchicine did reduce it. We looked at aspirin and rivaroxaban. In fact, again, the primary outcome of major thrombosis, death, mechanical ventilation, or high-flow oxygen was not different. And mortality was not different. And so, again, despite a lot of the hype around anticoagulation, we did not find a benefit from aspirin and rivaroxaban together. To put this research into context, we actually did an updated meta-analysis. And when you look at all the available trials of colchicine, and there were some trials suggesting potential benefit, it's completely neutral for mortality. The story is a little bit different with anticoagulation. When you intensify anticoagulation, you do reduce venous thromboembolism by about 40%. But that reduction in venous thromboembolism doesn't translate into a reduction in mortality, but it also increases bleeding. So it's really this interplay. I think the conclusion is that we should not be using colchicine in hospitalized patients with COVID-19. And aspirin and rivaroxaban were not beneficial, and we really need to think about the risk versus balance with regards to intensifying anticoagulation. Yeah, and I think the meta-analysis really puts it into context. We had hoped, there were signals of benefit in the COVID trial and the Corona trial in outpatients, that maybe colchicine was an inexpensive way and widely available way to improve outcomes. But that wasn't the case, and the meta-analysis now clearly shows that it doesn't work. I think it's really important for we really seen the event rates drop over time. So certainly these variants are less have less morbidity and mortality associated with them. But when patients get hospitalized, they're still very sick. So we really need to focus on therapies that reduce mortality and that are really widely available to the entire world, not just Western high-income countries. So I think we still need to search for therapies. Steroids was probably one of the most important innovations in the treatment of COVID-19, and we need to find further therapies that can reduce mortality and the need for mechanical ventilation in COVID-19.
mean, just look around you, right? At this conference, I mean, I think it was Dr. Cassidy who said that ESC is like a science festival. And I feel like, you know, as the in-person meetings, both ACC and ESC have, you know, returned, we have seen the science festival continue. What excites me is, you know, how much precision medicine we have achieved, not only with diagnostics, but also with therapeutic options. Yesterday, there were several trials with SGLT2 inhibitors that were, you know, shown to be positive. So I'm really excited about, you know, increasing options of guidelines-directed medical therapy, whether it is in heart failure or whether it is for prevention. You know, inclisiran was just approved by FDA. There's so many lipid-lowering medications we have. We can utilize advanced imaging, both CT, MRI, you know, to detect now the disease with, you know, a certain level of precision. And I think that this is going to impact prevention in general in cardiology. And, you know, the science that is coming out is so strong. And that, I think that's what keeps me excited to be in the field, and that's what keeps me going. I think I was a second-year medical student where I was found to have inverted P waves, which is an EKG abnormality. And, you know, I had to go to see a cardiologist back home in India while being in medical school. And I was told that it was a normal rhythm that can sometimes be detected in young patients. And that got me interested in cardiology. I read a physiology textbook, physiology, you know, of cardiovascular disease textbook within 2 days, like a storybook. And from there on, I was, you know, forever interested in cardiology. But I think as a diagnostician or an advanced imager, what excites me is that I'm that person in cardiology subspecialty who puts together the piece of puzzle. So there is never a dull moment. You know, you take patients' clinical presentation, you get all the diagnostics, you put it all together, you come up with a diagnosis, and then you have to choose the treatment, you know, based on what group that patients, you know, remains in, whether it is the age or the sex or the comorbidities. So I think there is like never a dull moment if you combine all of this, and you know, it's never boring, and that's what keeps me going in cardiology, and that's what excites me about cardiology. Hello, my name is Purvi Parvani, and I'm a cardiovascular advanced imager and a cardiologist at Loma Linda University Health, Loma Linda, Southern California, United States. And today I've selected 3 trials from European Society of Cardiology meeting 2022 to discuss with all of you. The first trial I have selected is called the DAN-CAVAS trial that describes the 5-year outcomes of the Danish cardiovascular screening registry. In this trial, 46,000 men aged 65 to 74 in Denmark were invited to randomize to comprehensive screening for subclinical cardiovascular disease or no screening in 1 to 2 randomization session, and were followed for cardiovascular outcome with a median 5.6 years follow-up. Now, this screening included non-contrast electrocardiographic gated computerized tomography to determine the coronary artery calcium score, and also to detect the aneurysms and atrial fibrillation, an ankle brachial blood pressure measurement to detect the peripheral vascular disease and hypertension, and a blood sample to detect diabetes mellitus and hypercholesteremia. The baseline characteristics and medications were balanced in both groups, and target enrollment was achieved in with almost 13.1% all-cause mortality in a control group after the median follow-up of 5.6 years. Now, the primary outcome here was death from any cause. Almost 10,000 men in the invited group underwent screening, and this counted for almost 63% of the patients. In intention to treat analysis, after a median follow-up of 5.6 years, almost 13% men in the invited group and 13% in the control group had died, so no significant reduction in primary outcome was achieved. Here, the hazard ratio of 0.95 and the confidence interval was 0.9 to 1. But in a pre-specified analysis, 11% reduction in primary outcomes was achieved in men between age 65 and 70. Also, in this study, there was a greater uptake of antiplatelet and lipid-lowering medicine that was seen in the screening arm, However, there was no difference in use of anticoagulation, antihypertensive, and diabetic drugs, or in coronary or aortic revascularization. Now, if we look at the cost effectiveness, this study had comparable screening cost effectiveness ratio per Cali as comparable to the breast cancer screening. In the study, although it was very important for cardiovascular prevention strategy, particularly given the benefit of increasing use of medications that we have seen with other CT trials as well, in the screening group, it lacked a comparator group for CAC imaging, and it did raise some serious ethical concern, having enrolled no women whatsoever. The trialists across the world have really called upon an action by the funding agency to not fund studies with any sex-based eligibility criteria, given that the cardiovascular disease remains the #1 cause of death for both the sex. The second trial that I have selected is called the DELIVER trial. DELIVER trial is dapagliflozin and heart failure with mildly reduced or preserved ejection fraction. This was presented along with several other studies that showed that SGLT2 inhibitors provide benefit to patients with heart failure irrespective of the ejection fraction. Now, in this trial, they almost enrolled 6,200 patients with mean age of 72 years and 44% women. These patients were randomized to dapagliflozin 10 milligram once a day or placebo on top of usual therapy, and they were followed for almost median of 2.3 years, during which time dapagliflozin reduced the rate of cardiovascular death or worsening heart failure with a number needed to treat of 32. Now, these results demonstrated, of course, the significant reduction in primary composite endpoint of cardiovascular death or worsening heart failure over the median follow-up of 2.3 years. The rate was 16.4 among the patients with mildly reduced or preserved EF that are treated with dapagliflozin versus 19.5 in the patients who received placebo. Importantly, the LV ejection fraction did not influence the result of this trial, and the effect of the medicine did not differ in the patients with ejection fraction above or below 60%. This is very relevant given that the Emperor Preserve trial had shown decreasing benefit of SGLT2 inhibitors with higher end of LVEF. This trial showed consistent benefit in every pre-specified group with strong evidence to support SGLT2 inhibitor in patients with heart failure regardless of ejection fraction, age, sex, or presence of diabetes mellitus. During the discussion of the trial, it was suggested by the discussants that these results can truly impact the guidelines, and perhaps these group of medicine will receive class 1 indication regardless of the ejection fraction. The third trial that I have selected is called the SECURE trial, also known as Secondary Prevention of Cardiovascular Disease in Elderly. This is an open-label trial that was conducted in 113 hospitals and involved almost 1,500 European patients with a mean age of 76 years. 31% of these patients were women, and all these patients had a recent type 1 MI within last 6 months. The median time between the index MI and randomization was 8 days. The baseline group had systolic blood pressure, mean systolic blood pressure of 129 and LDL value of 89 milligrams per deciliter. The poly pill that was used in this trial that included 100 milligrams of aspirin, 2.5, 5 or 10 milligrams of ramipril, and 20 or 40 milligrams of atorvastatin. Now, the physicians had the option of reducing the statin dose to 20 milligrams. Based on the patient's history or blood test results, almost 92% of the patients in this trial received the higher dose of statin, which was 40 milligrams of atorvastatin. The dose of ACE inhibitor was also started at 2.5 milligrams of ramipril in patients that were ACE naive and was gradually increased to 10 milligrams. Almost 40% of the patients received ramipril 2.5, aspirin 100 milligrams, and atorvastatin 40 milligrams. and almost 95% of the patients, both in both the arms, received an additional antiplatelet medicine, and 80% were also on the beta blockers. The primary outcome of this trial was cardiovascular death, non-fatal type 1 myocardial infarction, ischemic stroke, or urgent revascularization. As expected, adherence at 6 months was significantly better in the polypill arm, and this remained consistently well even at 2 years. What was surprising, though, that even though there was no significant difference in systolic or diastolic blood pressure between the two study arms, or there was no difference in the mean LDL level between the two arms, the treatment with polypill resulted in significantly lower risk of major cardiovascular events compared to the usual care. Now, the benefit of polypill was also again consistent across all the subgroups, including subgroups stratified by age, sex, CKD, prior revascularization, or diabetes mellitus. Now, the adherence to treatment, of course, can explain some of the reduction in the clinical outcomes. However, there was no reduction in the blood pressure or LDL between the two groups, which was truly surprising. And the lead investigators here have speculated that it might be explained by the pleiotropic effect of ACE inhibitors or statins, which were used widely in this study, or perhaps the aspirin in this polypill, even though the previous benefit with aspirin in clinical trial has not shown the benefit to a large extent as it was shown on the SECURE trial. Now, this study did have some limitations, given it was an open label design, and it was also underpowered, a bit underpowered given the COVID-19 pandemic. However, it adds to the data that we have seen previously, even with polypill in this case, in patients that had type 1 MI in last 6 months. So with this, I would like to conclude this video. Thank you so much for listening to me.
In 2022, we're seeing huge developments in the field and cross-functioning developments. So where you look at the intersection between the imaging world and interventional world and surgical world, it's really amazing. We're starting to evaluate our patients before they come to the cath lab to determine their risks, to determine feasibility of complete revascularization with the utility of non-invasive imaging and physiologic testing and so on. So I think this is a growing space that is very exciting, and it's why I'm still in the field. It doesn't get boring any day. I think the gratification is immediate, and it's one of the fields where we know we impact patient outcomes directly. So when a patient's presenting with a heart attack, an acute myocardial infarction, we know that even if we wake up at 2 o'clock in the morning and rush to the cath lab, we are going to improve this patient's survival. And that instant gratification that you touch from your patients directly, who are grateful and tell you about it, it really gives you the stamina to keep going in a difficult field. And that's really what I enjoy most about it. Hello everybody, my name is Mirvat Al-Asnaj. I'm an interventional cardiologist practicing in Jeddah, Saudi Arabia, and I'm here with Radcliffe Cardiology to present to you 3 of the most important trials in the interventional space that were presented at the European Society of Cardiology Congress 2022. I'm going to start with one of the most interesting trials, which was the revived BICS trial, and caused quite a stir when it was presented during the Congress. Now, this was a trial that enrolled 700 patients with impaired LV function, severely impaired LV function defined by an ejection fraction of equal to or less than 35%, with extensive coronary artery disease based on the BICS Jeopardy score. Viability was assessed in these patients, and it needed to be demonstrated in 4 segments, and the majority of whom were detected by MRI, cardiac MRI. There were several exclusion criteria which are important. Patients who had an acute myocardial infarction within the last 4 weeks, decompensated heart failure, and sustained ventricular tachycardia were all exclusions, and there was a 1-to-1 randomization to PCI with optimal medical therapy or optimal medical therapy alone. The mean age was 70, 88% were men, and the mean ejection fraction was 28%. The primary endpoint was a composite of all-cause death and heart failure hospitalizations, and the secondary endpoints were ejection fraction improvement at 6 months and 12 months, as well as improvement in quality of life parameters. So the results were surprising that just over the 3 years of follow-up of this trial, the primary composite endpoint of death and hospitalizations for heart failure occurred in 37.2% of the PCI arm and 38% of the optimal medical therapy arm. There was really no difference in the ejection fraction. With regards to quality of life at 6 months and 12 months, there was a notable improvement in the PCI arm, which was not sustained through 24 months. So overall, this was considered a neutral study. The next study was the radial trial, which looked at individual patient-level meta-analysis, and it was assessing the impact of transradial access versus transfemoral access on both major bleeding and mortality. This was a pooled data from 7 trials with over 21,600 patients. The mean age was 63.9%. Women were 31.9% of the cohort. 95% had an acute coronary syndrome, and 75.2% underwent percutaneous coronary revascularization. The primary endpoint was all-cause mortality at 30 days, and it occurred in 1.6% of the radial arm versus 2.1% of the femoral arm. And the co-primary outcome of major bleeding occurred in 1.5% of the radial arm and 2.7% of the transfemoral arm. And when they looked at subgroups such as acute coronary syndrome, PCI, protocol, as treated cohorts, all had a survival benefit with transradial access. And this was consistent in different subgroup analyses such as angina and women as well. So this was very favorable, looking at contemporary data on transradial access, and supports the current guidelines, both European and American. So the final study that I wanted to discuss with you is the FRAME AMI study. This was an investigator-initiated open-label trial that included 14 sites in Korea. FRAME AMI randomized patients with multivessel disease who had an acute myocardial infarction and successful PCI of the infarct-related artery to FFR-guided complete revascularization, i.e. FFR-guided revascularization of the non-infarct-related artery, and angina-guided of the non-infarct-related artery. FFR significance was considered anything equal to or less than 0.8, and angina and angio-guided was anything more than 50%. The PCI was done either in the index procedure, which was highly recommended, or at least index admission, but they did permit staged interventions. The primary endpoint was a composite of all-cause death, myocardial infarction, repeat revascularization. So a total of 562 patients were included. The age was, average age was 63, 16% were women, and immediate complete revascularization was done in 60%, and it was achieved in 40% for staged intervention. The follow-up was 3.5 years, and the composite endpoint of all-cause death, MI, and repeat revascularization occurred in 7.4% of those who got FFR guidance and 19.7% of those who got angio guidance only, and it was statistically significant. Looking at the individual components of the composite, when we look at death, it occurred in 2.1% of the FFR-guided group and 8.5% of the angio-guided group, again statistically significant. Myocardial infarction infarction occurred in 2.5% of the FFR-guided and 8.9% in the angio-guided alone. Again, this was statistically significant. And finally, unplanned revascularization occurred in 4.3% in the FFR-guided and 9.0% in those who were angio-guided. But this was not statistically significant. So overall, FFR guidance was consistent for both STEMI and non-STEMI patients in terms of guiding complete revascularization. Will this prompt a change in the guidelines? Perhaps too soon, particularly because it is focused in Korea and needs to be replicated elsewhere. So thank you very much for staying tuned. Other trials that I did not discuss at depth but are actually very interesting and were presented at ESC Congress looked at atherosclerosis detected by PET and predicting outcomes in terms of mortality and repeat cardiovascular events. And the second studies that were presented looked at anti-thrombotic agent, direct antithrombotic agents for patients with acute myocardial infarctions or stroke on top of intensive antiplatelet therapies such as prasugrel and ticagrelor. Remember, these were safety trials designed for safety endpoints and did not have the numbers, the adequate numbers to power them to give us cardiovascular outcomes. Nevertheless, they lay the foundation to prepare phase 3 trials for these agents in these subgroups. So thank you and hope to see you again in another episode.